So very good evening, all of you. So welcome to this test and discussion session in dermatology. I hope, please let me know in the chat box if the audio as well as the video is all fine or not. So Sakshi, Stuti, Mupin, all of you are answering that, yeah, it's all fine. Thank you so much. How are the preparations going? How is the test and discussions? Are you able to score well? Are you facing any difficulty? Did all of you give the test today for dermatology? Yeah, all the high. I'm just replying for all of your highs and yeah, pressure. Pressure should be there. No, a little bit of pressure is obviously there, but I'm sure that all of you will overcome the pressure. Okay, someone has scored 35 out of 50, anxiety. So we are starting the dermatology session with pressure, anxiety, etc. Yeah, don't worry. So the plan here is I will not try to stretch it too much. We'll have a very quick discussion. So I hope that all of you have done dermatology already. You must have done a quick revision before your test and discussion. Even if you have not done anything, just stay relaxed during the next few hours. What we will try to do is we will try to go topic by topic. I'll tell you what are the topics that is important for your exam. Just make sure that you go through those topics before you go for your exam day. Okay? And yeah, the most important question is, will I share the PDF? Of course, I'll share the PDF immediately after the classes. Yeah, whoever has scored 60%, 35 out of 50, all these things is fine. For this paper, I feel that if at all you're able to score somewhere around 65 to 70%, still fine, but try to stretch it a little more, okay, with your more MCQ practice. Fine. So shall we begin? Chalo. So let's start with the first question. So the first one, yeah, see, don't worry about the marks that whatever you have scored here. Maybe you scored 32, someone scored 35. It doesn't matter at all. Fine. So what is most important is whether you have covered all the important parts from the subject. And tomorrow when the questions come, during the course of this discussion, I'll tell you how the questions have been changing. Like we have seen a lot of change in the last NEET PG exam. So similarly, whatever changes are expected, I will try my best to discuss it during the discussion today so that you're well prepared. Fine. So now let's start with the first one. Which of the following layers of the epidermis is called as the Malpighian layer? Pretty direct question. Now, we know that there are a lot of layers in the epidermis. Now, what is that mnemonic which you can remember for this layers of the epidermis? Can somebody text in the chat box very quickly what are the layers of the epidermis, which you can remember as come, let's get sunburned, isn't it? Sunburned. Now, what is this come? C stands for? Very good. So C stands for stratum corneum. G stands for L stands for stratum lucidum. G stands for stratum granulosum. S for stratum spinosum. And B for stratum basale. Now, out of all these, what is the innermost layer of the epidermis? The innermost layer. Is it the corneum or is it the basale? Innermost layer. Very good. So this one, that is the stratum basale, is the innermost layer. So obviously, the outermost layer is going to be the stratum corneum. So this is going to be the outermost layer. So out of all these layers, there is a combination of two layers, which is called as the Malpighian layer. So what is that combination? Many of you have already answered in the chat box. Is it A, B, C, or D? The answer is the innermost layers of the epidermis together is called as a Malpighian layer, which means I'm sorry, some technical difficulty. Audible? Shall let's continue. I just got logged out. Okay, so the answer here is going to be option A, that is stratum spinosum and stratum basale. Now, out of all these layers, in case you get any question from this epidermis, then there is one question which you can expect when it comes to the exam is what is the layer which is formed towards the end, or what is the layer which is formed at the end? Or the question can be like, what is the layer that is deficient in a preterm infant? So if you get a question like what is a layer that is deficient in a preterm infant, what is a layer that is deficient? It is going to be the stratum corneum. Why is stratum corneum deficient in a preterm infant? Because this is the last layer to be formed. So this is the last layer to be formed. Now, there is one more thing that I would like to add here when we talk about the important topics from the epidermis is which is the most actively dividing layer? Which is the most actively dividing layer? Any answer? What is the most actively dividing layer of the epidermis? Very good. The most actively dividing layer of the epidermis is called as the stratum basale. It is called as the stratum basale. So that is all about the initial part of the epidermis. So in the epidermis, the first layer to be formed is stratum basale. Stratum basale and stratum spinosum together, we call it as the Malpighian layer. The last layer to be formed is the outermost layer, that is the stratum corneum. Fine. So all these are the important points as far as the epidermis is concerned. Yes, Atul, you will get this PDF as soon as the classes are over. So now let's see the second question. Identify the morphology of the lesion in the image. Now, what is this? So when you can see that there is an image, there is some skin rash. So think like how I'm explaining. So you can see an image, there is some skin rash. They're asking you whether it is a macule, it's a papule, a vesicle, or a nodule. So just zoom this image. Now, what do you think? Is it a macule? Is it a papule? Is it a vesicle? Or is it a nodule? Very good. So Pardeep, Garima, all of you are answering. So this looks like a vesicle. So the right answer here is going to be a vesicle. So what is a vesicle? The diameter of a vesicle is always going to be less than 1 centimeter. What if you are getting an image of with a clinical scenario that the patient spilled hot tea or coffee to the hands, and after that the patient came to you with multiple large lesions, that is fluid filled lesions, then what's the answer? Very good. That is going to be a bulla. So when it comes to a bulla, remember that the diameter is going to be more than 1 centimeter, and this is going to be a fluid containing lesion. It is going to be a fluid containing lesion. So these are the basic morphology of the skin lesions. Now, can anybody tell me an example of a papule? Any disease where you can see a papule? So let's have a quick interaction. Fine. So we cannot spend more time with one question. So tell me any one disease, whatever comes to your mind, where you can find a papule. I would say I will not tell you the names who is going wrong. I'll only call out the names who are making it right. But in psoriasis, I don't agree that you can find a papule. Chickenpox, I don't agree because in psoriasis, we can see plaque lesions. Chickenpox, we can see a papule, but mostly vesicles. So Akanksha is answering, Stuti, all of you are answering. Yeah, in acne vulgaris, we can find. Measles, yes, maculopapular eruptions, right? So in measles, yes, we can find papules. Now, can you tell me some diseases where you can find vesicles? Some diseases where you find vesicles. Just keep your brain into work. Think what are the diseases where you can expect a vesicle. Very good. Chickenpox is one. Another answer in the chat box. is herpes zoster. Very good. There is one more herpes. What is that? Herpes simplex virus, HSV. So what is the mistake that I'm seeing in the chat box here is some of you are saying molluscum. So please remember molluscum contagiosum. It is a dome-shaped umbilicated papule. It's not a vesicle. Okay, so whoever is answering it as molluscum. So please remember molluscum contagiosum is a viral infection. It's not a vesicle. It's going to be a papule. Very good. Now, any cases where you can find a bulla. So what are the diseases which comes to your mind when I say that the patient presents to you with a bulla, a large vesicle more than 1 centimeter? Burns, I would agree to you that in burns we can find bulla. Any other diseases in dermatology? Very good. You can find it in pemphigus vulgaris. You can find it in bullous pemphigoid. See, why am I emphasizing on all these things is that what is actually tested on the day of your exam, rather than hi-fi concepts, they always test you with the basics. So if you understand these kind of basics, it is less likely that you can make a mistake on the day of the exam. Clear? Now tell me, what are the diseases that comes to your mind when I tell that patient has a plaque lesion? Plaque. Plaque means it is multiple papules coming together to become a larger lesion. Very good. One of the answer I can find correct in the chat box is psoriasis. Yeah, most of you are saying psoriasis. Anything else? Whoever is answering impetigo, remember there are two types of impetigo. One is bullous, the other one is non-bullous impetigo. You will not find plaques in impetigo. So yeah, leprosy. Very good. So somebody is answering it as leprosy. Remember one very important disease which also will present to you with plagues. It starts with L. Another clue is it is having a violet color or a purple colored skin. Any answer? Very good. This can be seen in lichen planus. Now, which type of tuberculosis can present to you with plaque lesions? Tuberculosis of the skin, which can present to you with plaque lesion. Anyone who's answering scrofuloderma, answer is wrong. It can be a nodular lesion. Okay. Yeah, which type of skin tuberculosis can present to you with plaque lesion? Try to remember what is the name of the tuberculosis of the skin. Most common type of tuberculosis is vulgaris, right? So what vulgaris is that? Yeah, lupus vulgaris. So please don't forget, lupus vulgaris is an important topic for your exam. So in lupus vulgaris, the patient can present to you with a long-standing history of a plaque lesion. Long-standing history of a plaque lesion. So these are some of the very common diseases. Reason is all these things like vesiculobullous disease, okay, whereas plaque, papillosquamous disorders, these are separate chapters by itself. So remember all these names based on the morphology of the lesions. Any queries, feel free to ask in the chat box anytime. We'll interact and go. Yeah, anatomical warts, it can be considered as a plaque lesion, Gayatri, but that is mostly considered to be a warty type of tuberculosis. It's called as a TBVC. See, in diphtheria, why am I'm asking here about the skin lesions, okay? So that is the only difference. So that's it. So now let's go to the next one. A 7-year-old patient presented with a hair loss and itching of the scalp. Which of the following is useful for diagnosis? Now all of you concentrate here. Most commonly asked type of questions for FMG is something like this. When you come out of the examination hall, when we ask you, do you remember any recall questions, which topics were asked? The main reason why you don't recall is the question itself is non-specific. Something was there in the scalp. They asked us, what is the investigation? So this, you should be prepared with these kind of questions. So when you get these kind of questions, the first few things that you have to look for is the age. Always look for the age. 7-year-old, it's a child. The child is having a hair loss and some itching as well. Now, once you examine the image, what do you find in the image? There is some crusting, there is some scaling and all, isn't it? So the first thing that I want all of you to remember on the day of exam, if it is a child, don't think about any hi-fi diseases like tuberculosis. Don't think about, any other psoriasis. Don't think about vitiligo. Think about the common ones. It can be an infection. Now, what is the answer here? Do you want to do a Zang smear? Do you want to do a gram staining, slit skin smear, or a KOH mount? Very good. So here the answer is going to be a KOH mount. You know the main reason why KOH is the right answer here, because fungal infections of the scalp is very common in children. Is very common in children. Out of the very, very common fungal infections of the scalp, can anybody tell me few names of fungal infections of the scalp? Now name the diseases. What can happen in the scalp? Very good. I can see that one of you is answering as Kirion. Second one, yeah, which is seen in child from Kashmir, something endemic to Kashmir. What is it? Very good. It is called as the favus. Anything else? Something it looks like you have shaven off the scalp hair. It's called as the black dot. And the last one is called as the gray patch. So all these are the examples of one single disease. It's called as the tinea capitis. It is called as the tinea capitis. Now imagine that on the day of the exam, the same MCQ is asked. 7-year-old child, itching, hair loss, etc. What is the treatment of choice? What should be the treatment of choice? When it comes to tinea capitis, any antifungal agent that comes to your mind? Yeah, Hanan, it's not something. Yeah, you're correct. It is griseofulvin. Very good. So this is going to be griseofulvin. And remember one very important thing, like in most of the FMG exams, they usually ask you about tinea. Why tinea? Because this tinea is a very, very, very common type of a skin disease. Now, in case they ask you about tinea corporis, tinea pedis, tinea unguum, tinea, or any type of tinea cruris. So the point here is the treatment or the drug of choice in all other types of tinea. So what is the drug of choice in all the other types of tinea? Like tinea cruris, tinea corporis, tinea pedis, etc. Very good. Answer it in the chat box. Try to answer. It is okay to make mistakes today. If you make mistake today, then you will definitely make it correct on the day of the exam as well. Fine. So yes, the answer here is very good. It is going to be terbinafine. So all of you, please highlight this. Every tinea is treated with terbinafine, except when it comes to scalp. And in the cases of scalp, it can be treated with griseofulvin, which is considered to be the drug of choice. Which is considered to be the drug of choice. So is it clear? Shall I move to the next question? Shall next one. A 45-year-old woman. Now, this is another type of MCQ. What happens? You have to complete 50 sets of questions in a stipulated time. Then we have to go to the next set. So what is very important for your exam is going to be your time management. So when it comes to time management and when you see very long MCQs, try to pick up the most important keywords in the MCQ. So now let's start to pick up the keyword in the MCQ. 45-year-old, let's keep 45-year-old in our mind, presents with a painful, rapidly enlarging ulcer. So what should be in your mind? 45-year-old, ulcer, usually painful, there is an ulcer in the leg. Ulcer has characteristic undermined, violaceous border and a purulent base. That is the characteristics of the ulcer. She reports a history of similar ulcers in the past. So she is getting an ulcer, healing, getting an ulcer, healing, isn't it? Which healed with significant scarring. Actually, this sentence has no significance. Reason is every ulcer heals with scarring. So this is only to deviate your mind. Now, still continue reading the question. She also has a history of ulcerative colitis. Now, this should ring a bell. Fine. There is a history of ulcerative colitis and somebody is having an ulcer which comes and goes. what comes to your mind? What is the non-healing type of ulcer which is usually associated with ulcerative colitis? Yeah. So I'm getting many of the answers in the chat box, and most of you are getting it right. I hope everyone gets it right. Nobody should make a mistake. It's going to be pyoderma gangrenosum. So pyoderma gangrenosum. So remember, what is important for your exam is, in case you get a question on the day of the exam, that there is an ulcer in the lower limb, and this is seen in a merchant. This is seen in a merchant. What is the most likely ulcer that you can see in anyone who is having a occupational history of long standings, like standing for long hours? Very good, Gayatri. So in such cases, more likely is a venous stasis. Okay, so someone, a homemaker or a housewife who is standing and working in the kitchen for long hours, they end up in getting a varicose vein. Someone who is a merchant, a sales representative, they may end up getting a varicose vein. So this can be a varicose ulcer. Fine. Now the second one is, any patient, if the question says who is a chronic smoker and is getting multiple painful punched out ulcers in the lower limb. So in such cases, what are you going to suspect now? Chronic smoker, he's having some claudication kind of a pain, or is complaining of a very painful ulcer. Is it venous or is it arterial? Think, what is it? Is it venous or is it arterial? Please chat message in the chat box. Yeah, this can be arterial ulcer. This can be arterial ulcer. So to differentiate between these things, like whether it is a venous ulcer or whether it is an arterial ulcer, is there any investigation that you can do? Is there any investigation to understand what is happening with the arteries, whereas what is happening with the veins? Any investigation? The reason why I'm asking you, trying to correlate multiple subjects now, is because you have done with all the subjects now. It's time to integrate them together. Yeah, what is it? Very good. Garima is answering. How many more can answer? PS is answering. Neha is answering. Very good. So the investigation that you can do is a USG Doppler study. Okay, you can do a USG Doppler study. So if you send a patient for a USG Doppler study, you will get the answer from the ultrasonologist, isn't it? That there is vascular stasis or there are arteries that have shrunken, isn't it? So that will give you more an idea of what is the diagnosis. Instead, now when the question says that there is a patient who is having an ulcer anywhere in the body, so don't get confused. It's not in the lower limb anymore. It can be over the stomach. It can be over the buttocks. It can be over the lower limbs. So ulcer anywhere, which is going to be associated with, what are the common associations? The associate, is my screen stuck? No, right? So if there is an association with hematological malignancy, irritable bowel disease, or rheumatoid arthritis. So in this case, think about pyoderma gangrenosum. In this case, you think about pyoderma gangrenosum. So is it clear? So on the day of the exam, don't get confused. Whenever you see any non-healing ulcer, think about venous, think about arterial, or if there is an association between with hematological malignancy, ulcerative colitis or Crohn's disease, both are part of irritable bowel disease, or with rheumatoid arthritis, then think about pyoderma gangrenosum. Shall I proceed further? So now let's go to the next one. A 45-year-old diabetic patient presented with a gradually progressive annular plaque with raised edges over the forearm. What is the most likely diagnosis? Again, I will just follow the same methodology. 45-year-old should be in my mind. there is a diabetic patient, so whether there is any association of this disease with diabetes, and there is an annular plaque, a round annular plaque with raised edges. So what comes to your mind? Some of you are saying C, some of you are saying D. What is the right answer? More answers in the chat box, please. What is it? Yeah, very good. So maximum number of answers in the chat box now goes to this disease that is called as the granuloma annular. So remember what happens in granuloma annular. What are the skin changes in diabetes? So what are the skin changes in diabetes? One of the skin changes that you can see in diabetes, which is very common, is called as granuloma annulare. Granuloma annulare. This is one of the very common skin change that you can see in diabetes. Along with that, there can be many other changes also, like necrobiosis, lipoidica, diabetic corum. Okay, these are some of the important skin changes that you can see in diabetes. Now, the important thing that you will remember when it comes to granuloma annular is that there is a rounded lesion. So, and this rounded lesion will be having a raised border. Will be having a raised border. So, any rounded lesion with a raised border, there is one more very close differential diagnosis in this MCQ. What is that? ABCD, what is a very, very close differential diagnosis? Yes, Akanksha is right. Tinea corporis, because tinea corporis also presents in this way. Okay, it also presents in this way. But if in case it is tinea corporis, there was no need for the examiner to mention about a diabetic patient. So if the question says diabetic patient with annular lesion, think about granuloma annular. It's a self-limiting condition. It goes away by its own. So it just looks like a rounded lesion with a raised border, Whereas in tinea corporis, what are the things that is differentiating in tinea corporis? What are the features of tinea corporis? It is commonly called as a ringworm. So this is also going to have annular lesion. This is also going to have a raised edge. Will there be itching or not? Itching, tinea, ringworm? Yes. So there would be itching and there would be central clearing. There would be central clearing. And what is your investigation of choice when it comes to tinea corporis? Very good. Somebody is adding peripheral scaling. Very good, peripheral scaling. What is the investigation of choice here? The investigation of choice is KOH. And how will you treat tinea corporis? Same thing we have discussed few minutes ago. Yeah, the treatment should be terbinafine. Terbinafine. So that is the difference. So just when you see annular lesion, raised edges, don't go behind tinea corporis. Make sure diabetes is not mentioned. If diabetes is mentioned, what is the answer? Granuloma annular. That is going to be the more likely thing when it comes to granuloma annular. Shall I make one more change? So before I go to the next question, I just want to make a slight modification to this MCQ. Can you listen to me carefully? Just 1 second here in the chat box. Just listen to me carefully. Same question. I'm just going to modify it a little. A 45-year-old diabetic patient presented with gradually progressive annular plaques with raised edges over the forearm. Patient reported positive in KOH. What is the answer now? What is the most likely diagnosis? So if the question is mentioning KOH positive, even if it is a diabetic patient can also get fungal infection, correct? So then at that case, the answer would be tinea corporis. The answer should be tinea corporis. So that is all about this MCQ. So with your permission, I'm going to the next one. A farmer presents with a solitary lesion over the foot, as shown below. What is the diagnosis? Sporotrichosis, TBVC, mycetoma, botryomycosis. So all of you remember that this has been one of the topic which is repeatedly tested for the FMG exam. Almost always they used to ask you about mycetoma. Remember, anyone who is presenting to you with a large swelling of the ankle, then think about mycetoma. Now quickly let us try to mention what is the triad of mycetoma. So what's the triad of mycetoma? Do you remember? What are the triad? Triad means there are three features. What is the first feature of mycetoma? There is a tumor-like soft tissue swelling. So in simple words, large swelling. Okay? Now, along with the swelling, what can be seen? Yes, you can see sinus tracts can be seen. Sinus openings are seen. That is the second point in the triad. And what is the third point in the triad? What comes out of the sinus? Yes, discharging grains. Discharging grains come out of the sinus. So this is a triad of mycetoma usually seen in farmers, etc., isn't it? Now, yeah, Ashwin, I'm coming to that point. Now, what we do is from this granules that is being discharged, we will send the granules for investigation. So these grains can be either positive for a bacteria or these grains can be positive for a fungus. It can be positive for a fungus. So if this is going to be positive for a bacteria, what is the name of the disease? Mycetoma is general. Madura foot is general. But to be very specific, bacterial Madura foot, what do you call? Actinomycetoma. Very good. Actinomycetoma. And if it is positive for a fungus, what do you call for that? Fungus should be the true. True means U. Okay, this is going to be Eumycetoma. It is going to be Eumycetoma. So remember all these things, all these important points. But so far, they did not test you regarding actinomycetoma or Eumycetoma. A large swelling over the ankle. Please remember this T&D discussion. Go for the right answer. That is going to be mycetoma. Now, among all these things that is mentioned in this MCQ, which among the four options is also called as the Rose-Gardner's disease? Which among the all four options is called as the Rose-Gardner's disease? Very good. So sporotrichosis is called as Rose-Gardner's disease. All of you still remember how will a patient present to you with a Rose-Gardner disease? So when it comes to a Rose-Gardner disease, you can see that there are multiple nodules which is arranged linearly. So this is the linear arrangement of nodules that can be seen. Okay, nodules arranged linearly. So instead of the foot, this time for the FMG exam, if you are going to get an image, something like a forearm, in the forearm, you can see multiple nodules and these nodules are arranged in a line linearly. Then think about sporotrichosis because the lesions are running along a lymphatics, that is running along a lymphatics. So all the other options, I hope TBVC we have discussed, that is the Wati type of tuberculosis. Yeah, Mahesh and Stuti is adding 2 points because in this you can find a star-shaped bodies. What are the names of the star-shaped bodies that you can see in histopathology of sporotrichosis? Yeah, this is called as the asteroid bodies. These are called as the asteroid bodies. And how will you treat a Rose-Gardner's disease? Treatment of a Rose-Gardner's disease. Yeah, very good. The treatment should be itraconazole. The treatment should be itraconazole. So someone is asking about how can we differentiate this linear nodules from chromoblastomycosis. So rather than me, can anybody answer in the chat box so that I can read it loud? How can you differentiate Rose Gardner's disease from chromoblastomycosis? Very good. So Mahesh is saying based on histopathology, copper penny bodies can be seen. Stuti is saying that you can find cauliflower-like growth. Very good. These 2 points, please keep this in mind. Like if you want this information about chromoblastomycosis, remember cauliflower-like lesion. And in the histopathology, remember, you can find copper penny bodies. Copper penny bodies. Clear? So with that, we have touched almost everything that comes under deep fungal infections. Okay, this copper penny bodies, they have different names. If you remember, medlar bodies, sclerotic bodies, muriform bodies, etc. So whatever they give you on the day of the exam, remember these are going to be chromoblastomycosis. Chromoblastomycosis. Is it clear? So now let's move to the next one. No, just a minute. One more query in the chat box. Can you differentiate between botryomycosis and mycetoma? Can anybody answer how can we differentiate mycetoma and botryomycosis? Because both these conditions, it is going to be a farmer who presents to you with a swollen ankle. Now the differentiating factor with botryomycosis is based on the organism. So if it is caused due to Staph aureus, then think about botryomycosis. Okay? So any patient coming with a large swollen ankle and on gram staining, you find that, or on culture, you find that Staphylococcus aureus is isolated. Then the answer would be botryomycosis, because Staphylococcus aureus does not cause mycetoma. Staphylococcus aureus does not cause mycetoma. Clear? Fine. So now let's go to the next one. What is the rarest form of leprosy? So we all have learned that leprosy in micro, in PSM, in dermatology. So we know that leprosy is considered to be a spectrum of disease. Tuberculoid spectrum, lepromatous spectrum. Out of which is the rarest form? Rarest one is the one that neither falls into tuberculoid form, neither falls into lepromatous. What is that? BB, isn't it? So borderline type is going to be the most borderline is considered to be the rarest type of leprosy. Now tell me, what is the most common type of leprosy? Most common type of leprosy. Very good. The most common type of leprosy is going to be BT type of leprosy. And in leprosy, where do you find maximum bacterial load in leprosy? Options are TT, BT, BB, BL, LL. Maximum bacterial load in leprosy can be seen with box, please. Maximum bacterial load. Yeah, that can be seen in lepromatous type of leprosy. So in which type of leprosy can you find a saucer right way up appearance? Saucer right way up. You know, the cup and the saucer right way up appearance can be seen in TT type of leprosy. And who remembers, where do you find satellite lesions or pseudopodia? Which type of leprosy can show satellite lesions or pseudopodia? Very good. This can be seen in BT type of leprosy. And where do you get a inverted saucer appearance or a Swiss cheese appearance? Swiss cheese can be seen in borderline type of leprosy. Now, along with that, now in which type of leprosy can you find a leonine facies or a lion-like face. Leonine facies or lion-like face. Yeah, this can also be seen in lepromatous type of leprosy. Can you add a few more points into lepromatous leprosy? Because this has been a repeat question for you. So in lepromatous leprosy, what are the other features? Do you see so many lesions, numerous lesions, or you see very little number of lesions? Yeah, numerous lesions. And do you see symmetrical lesions or asymmetrical lesions when it comes to lepromatous leprosy? Yeah, symmetrical lesions. So symmetrical lesions can also be seen. What happens to the nose in the case of a leprosy? Nose. What happens to the nose? Is there any name to the nose? Yeah, very good. You call it as a saddle nose deformity. Saddle nose deformity. What will happen to the voice in the case of lepromatous leprosy patients? Yeah, this is called as a hoarseness of voice. So the patient will complain of hoarseness of voice. What will happen to the eyebrows to a patient of leprosy? Yeah, loss of eyebrows, loss of eyebrows. And last, one more question. What is the primary skin lesion or the morphology of the skin lesion over the face? Over the face, do you expect a macule, a patch, a nodule, a papule? Yeah, you will get multiple nodules over the face. Multiple nodules over the face. So all these are going to be the characteristics of lepromatous type of leprosy. So be prepared. You may get a hypopigmented patch with a loss of sensation, isn't it? Sensation can be either touch or temperature. So in the such cases, if they give you all these keywords, like the patient is having a saucer right way up, patient is having satellite lesions, inverted saucer, etc., then only you will be able to differentiate the type of leprosy that is given. So moving to the next question. A 45-year-old male presented with multiple hypoanesthetic, mildly erythematous small plaques on the trunk. His ulnar nerve and lateral popliteal nerve on both the sides were enlarged. What's the probable diagnosis? So these are the type of questions where you may get confused because nothing very specific is being asked. What are they trying to test you here is they're just trying to test your basics. Now, the thing that you have to apply here is, in which type of leprosy do we expect maximum nerve involvement? Is it in the tuberculoid spectrum? Is it in the borderline spectrum or the lepromatous spectrum? That is the thing that should run to your mind. Maximum nerve involvement. So maximum nerve involvement always happens when it comes to lepromatous leprosy or towards the lepromatous spectrum. So in case they don't give you an option of lepromatous leprosy, then see which is more inclined towards the lepromatous spectrum. Is it borderline leprosy, borderline lepromatous? I think two of the options are same, right? So in case lepromatous leprosy is not given, the second best answer here in this MCQ would be borderline lepromatous leprosy. Now, few words regarding the treatment of leprosy before we go to the next question. So I hope all of you are with me. Now tell me, in case there is less than 5 skin lesion and there is no nerve involvement, what do you call for this type of leprosy in the context of treatment? Very good. You call it as paucibacillary. Whereas in case you have more than 5 skin lesion or at least involvement of one nerve, then what is it called? Is it paucibacillary? No, it is called as multibacillary. So why do you count the number of skin lesions? Why do you check for the involvement of the thickening of the nerves or the involvement of the nerves? That is for the purpose of treatment. Very good. Stuti, Abhishek, all of you are answering. Now, what is the difference between paucibacillary and multibacillary? when it comes to treatment? Are we using different drugs for both? Do we use different medications for both? No. The medications that is used is going to be the same. What are the three medicines that is used? The medicines are D stands for Dapsone, R stands for Rifampicin, and C. What is C? Yes, clofazimine. Clofazimine. So Dapsone, Rifampicin, clofazimine is used. Now tell me the duration of treatment when it comes to paucibacillary. Paucibacillary, we treat it for 6 months. Whereas multibacillary, we treat it for 12 months. So remember, that is about the treatment part of leprosy. That is a treatment part of leprosy. So shall I move to the next question? A 5-year-old girl presents with fever, vesicles over the hand, feet, and oral cavity. Which of the following is a likely causative organism? Enterovirus, parvovirus, Coxsackie virus, Epstein-Barr virus. Very easy, right? First, tell me what is the diagnosis here. First, tell me the diagnosis. Yeah, Meghna, this is called as hand, foot, mouth disease. So in hand, foot, mouth disease, this is a viral infection. And the most common virus which causes hand, foot, mouth disease is called as the Coxsackie virus A16. There is one more virus which is given in this option which can also cause hand, foot, mouth disease. What is that? Very good. This one, enterovirus EV71, can also cause hand, foot, mouth disease. Can also cause hand, foot, mouth disease. Okay? But in case there is no neurological complication, then the most common organism is going to be the Coxsackie virus. Can you name a disease which is caused by parvovirus B19? What happened to the chat box? All of you got stuck. So what is a disease which is caused due to parvovirus? Yeah, very good. Fifth disease. So this is called as the fifth disease. Now, what is the appearance of the fifth disease in a child? Does the child come to you with erythema over the trunk or erythema somewhere else? Yeah, it has a slapped cheek appearance, right? So it has a slapped cheek appearance. So it has a slapped cheek appearance. Now, can you tell me anything that is related to dermatology where there is a mucosal infection that can be seen within the oral cavity, which is caused due to Epstein-Barr virus? No, not measles. Not measles for sure. Yeah. Okay, some of you are saying infectious mononucleosis, TK, but I'm asking dermatology. Okay, something that is related to the skin. No, Koplik spot is seen in measles. No, not correct. So here there is one condition which is affecting the tongue. Okay, there is a condition that can affect the tongue, which is called as the oral hairy leukoplakia. So what is happening when it comes to oral hairy leukoplakia? So if this is the tongue, there is a hairy lesion on the lateral part of the tongue. On the lateral part of the tongue. It is usually caused due to Epstein-Barr virus, and this is usually seen in immunocompromised patients, which means it is usually seen in HIV patients. It is usually seen in HIV patients. Okay. That is it. So in the chat box, I can see that some of you are getting confused. So all of you should have a clear idea about what is happening when it comes to mumps, isn't it? So there is a swelling over the parotids, isn't it? So what is happening in measles? Generally, there is going to be a reddish rash. So any patient of measles will come to you with 3 symptoms. What are the 3 symptoms? Fever, cough, coryza, isn't it? Sometimes conjunctivitis also. So when you see fever, cough, coryza, conjunctivitis, maculopapular rash, what is seen in the oral cavity? Koplik spots. Think about measles. Okay? Now here I was talking about Epstein-Barr virus. So since I saw different types of answers in the chat box. That is the reason why I jumped into this one. Yeah. So now let's go to the next question. What is a causative agent of anogenital warts? Now all of you please concentrate that this is one topic just like mycetoma, repeated almost every exam, FMG exam. Okay? So pay attention, have a good idea about anything that can be asked from anogenital warts. Is it HPV 2, 6, 5, 8? So who is making mistake here again? You don't make a mistake. So here the right answer would be human papilloma virus 6 and 11. So these are the most common type of HPV which causes anogenital warts. Now what is the common name of anogenital warts? Anogenital warts otherwise can be mentioned in the MCQ as condyloma acuminata. So this can be otherwise called as condyloma acuminata. So during our previous discussions about various topics, in which disease did we talk about condyloma lata? Condyloma lata was associated with, please answer in the chat box. I mean, getting answers, correct answers, but I want more of you to answer so that there is a good interaction. You will be able to memorize whatever you have learned in the past, isn't it? Yeah. So condyloma lata is seen in syphilis. Which type of syphilis? Primary, secondary, tertiary. So this can be seen in secondary syphilis. Whereas condyloma acuminata, these are warty lesions in the genitalia. And it is caused due to HPV 6 and 11. This HPV 6 and 11, is it a high risk subtype or a low risk subtype? High risk or low risk? Very good. So this is going to be a low risk subtype of human papilloma virus. When I say that HPV 6 and 11 is a low risk subtype, what am I telling the patient? What am I conveying to the patient? That you need not worry, that this is not going to convert into any type of a malignancy. Now, which is the type of human papilloma virus which is considered to be a high risk subtype? High risk subtype, which means which can convert to a malignancy. That is going to be 16 and 18. So whoever is answering in the chat box, very good. Keep going, all good. So high risk. Now, what is this high risk? What cancer is it going to progress into? So this is going to progress into cervical cancer. Cervical cancer. Now, a few more things regarding this condyloma acuminata. So in condyloma acuminata, so all of you know about different types of antiviral agents. Let us say acyclovir. So can I prescribe an ointment of acyclovir to a patient who is having genital warts? Yes or no? So we should have this concept crystal clear before your exam. Is there any role of antivirals in the management of condyloma acuminata? Yeah, there is no role. So please note down, no role of antivirals in the treatment of anogenital warts. There is no role. So there is no role of acyclovir, there is no role of ganciclovir, there is no role of oseltamivir or any other antiviral agents that you know. Then what is the treatment of condyloma acuminata? Or let me ask you, what is the treatment of choice? So treatment of choice, if many of you are answering excision, cryotherapy, remember, wrong answer. HPV vaccine, Gardasil, you can give, but that is again not the treatment of a wart. Patient is coming to you with large genital warts. So here the treatment is immunomodulatory agents. So do you remember what are the examples of immunomodulatory agents? Very good. This is called as imiquimod. So this can be imiquimod. Remember? So the treatment of choice, okay, treatment of choice in anogenital warts can be imiquimod or podophyllins. Imiquimod or podophyllins. And since imiquimod and podophyllins, this cannot be prescribed for anyone who has conceived or who is pregnant. So in such cases, the treatment in pregnancy is going to be cryotherapy. The treatment in pregnancy is going to be cryotherapy. So please do remember all these points because condyloma acuminata is always asked. So you may find some image of a cauliflower-like lesions in the genitalia. Think about genital warts. There is no role of antiviral agents. You can better treat it with imiquimod podophyllins. But if the question says that a patient who has conceived is in the second trimester of pregnancy and we are going to treat this patient, then the answer should be cryotherapy. Why are we treating the patient during pregnancy? Because there is an increased risk of transmission of the virus from the mother to the baby during the birth, isn't it? During the birth. So what is the type of warts in neonates that can be seen passed on from a mother? So please answer this one. That is the last question for this topic. So if a mother is having anogenital warts and the mother is not taking a treatment of anogenital warts, she is having a normal delivery. During the normal delivery process, the warts or the virus is getting transmitted from the mother to the baby. So what is the type of warts that a baby can get? The type of warts the baby can get is Mupin Chandra is answering it right. Atul is answering it right. This is called as laryngeal warts. So for your exam, if they ask you which type of HPV causes laryngeal warts in infants, the answer would be HPV 6 and 11. Reason? Mother had 6 and 11 in the anogenital warts. Okay? Done. So now let's go to the next question. A 16-year-old male presents with severe itching for 2 months. The itch is relentless, especially at night. Examination findings are shown below. What is the common distribution of this infestation? First, tell me what is the diagnosis. Again, we always will keep this in mind, 16-year-old. There is severe itching, especially at night, increased itching during night. So when you see this nocturnal exacerbation, all of you will start thinking about scabies. Very good. So this is going to be scabies. Now, what is the typical lesion that is shown in this image here? So what do you call for this S-shaped serpiginous pathway that you can see over the skin? Yeah, so this lesion is called as the burrow. So these are called as the burrows, typical lesions in scabies. So where do you look for the burrows? Like the question is asked, the question here is, what is a common distribution? Remember, we look for the burrows in some circle. What is it? Is it circle of Willis or some other circle? Very good. It is a circle of Hebra. So we look for the burrows in the circle of Hebra. So what is the circle of Hebra? In between the finger webs. Then you look for the wrist area. Then you look for the forearm. Then you look for the axilla. Then the areola around the nipples. Then over the umbilicus. Then over the groin. So this forms a circle. This is called as a circle of Hebra. Now read all the options. Neck, hands, face. Between fingers, on the wrist, around the waist. Wrist, ankle, legs, scalp, flexural surfaces. What should be the most appropriate answer? Zishan, Abarmagi, all of you are answering it. Yeah. So here the most appropriate answer should be B. In between the fingers, on the wrist, around the waist. This is going to be the distribution. This is going to be the distribution. Now quickly tell me, how are you going to treat a case of scabies? What's the drug of choice? 1%, 2%, 5%. Anyone saying 1%, remember, wrong. Yeah, this is going to be 5% of permethrin. Very good. So in case of severe cases, treatment resistant cases, can you tell me a oral drug which can be used? So in severe or resistant cases, any oral drug, very good. This is going to be ivermectin, can be used for the management. So that is going to be the treatment of scabies. That is going to be the treatment of scabies. And finally, what is the organism which causes this infestation? Name the organism. You remember what is the causative of scabies? Very good. That's called as a Sarcoptes scabies. Sarcoptes scabies. Now I have one more question. Which is the investigation which will show you a Sarcoptes scabies? How can you find? Will you go for a culture? Will you go for a KOH mount? Will you go for a gram staining? What is it? Yeah, very good. This is going to be KOH. Okay, potassium hydroxide mount will show you Sarcoptes scabies. So one more question about the burrows. True about the burrows of scabies is all except burrow is seen in stratum granulosum. Burrow appears yellow on wood slab. Burrows are located in the distribution Hebra cycle. Burrow is a classical sign of scabies. Yeah, what's the answer here? What is wrong? True is all except. So this one is wrong, right? So where do you find burrow? It's very, very superficial. That is why we have a raised lesion. So in which layer do you find a burrow? The burrows can be seen in stratum corneum. So the burrows can be seen in the stratum corneum. All the others are right. The wood slab examination is not a very common finding. But remember, the burrows, they may appear slight yellowish on wood slab examination. So these are the lesions of burrows. So if you do a wood slab, this can appear yellowish. That is about burrows. So now let's move to the next question. A 70-year-old man, 70-year-old, has a lesion over the face since 3 years. What is the diagnosis? So here, all of you, please concentrate here. For when you do your MCQs for any of the subjects, then whenever you see above 60, always you keep your differential diagnosis one step ahead with malignancy. So there is a 60-year-old patient who is complaining of blood in the stools. There is a 60-year-old patient who is complaining of hemoptysis. There is a 60-year-old patient who is complaining of some lesion. Everywhere, be it medicine, be it surgery, when the age increases, like above 60 years old, keep one of your top preferential differential diagnosis as some kind of a cancer. Now here also, what is it more likely? Malignant melanoma, SCC, melanoacanthoma, BCC. Yeah, so I think all of you has got it right. This is called as the basal cell carcinoma. Can you tell me what is one point that helps you to reach out to this diagnosis of basal cell carcinoma? One is based on the age. Second one is the location of the lesion. What is the location? Face. Face is the most common location where you find a basal cell carcinoma. And usually the basal cell carcinoma, it has a rolled up border. But here that rolled up border is not very much visible, isn't it? So this is most likely the one that you call as a rodent ulcer. So this is most likely rodent ulcers. What does a rodent ulcer do? A rodent ulcer usually is going to destruct the underlying tissues, right? This is going to destroy the underlying tissues. Now, when it comes to the face, I just want you to remember what is the treatment of a rodent ulcer. Remember, which is a part of our body where we want to keep it as presentable as possible. We want to be very much presentable with which area? The face, isn't it? So when it comes to the face, we will not take the blade. We are not going to do a big excision and all. What are we going to try to do? We go for a microsurgery, isn't it? And with the help of a microscope. So this is called as the Mohs micrographic surgery. So this is going to be the treatment of basal cell carcinoma. This is going to be a treatment of basal cell carcinoma. Before we go to the next one, I just want to make sure that any question that comes from this topic of carcinoma, skin cancers, you are getting it right. Suppose you get a patient who is having malignant melanoma. How are you going to see an image and how are you going to make out a diagnosis of malignant melanoma? Is always going to be a black lesion, isn't it? Black colored mole. And you will always try to evaluate a malignant melanoma with A, B, C, D, E. Can you quickly tell me what is A, B, C, D, E in the chat box, please? What is A? A stands for asymmetry. What is B? B stands for border irregularity. Very good. C, color. D, increasing in diameter, isn't it? D is diameter. What is E? Yeah, it is going to be evolving in color, size, and shape. That is how. So if you get any image of malignant melanoma on the day of the exam, you're always gonna get this thing right. Now, you will never get a direct question about squamous cell carcinoma, but just one sentence here. Which is the malignancy with maximum number of pre-malignant lesions? Which maximum number of pre-malignant lesions, that is going to be your squamous cell carcinoma. So if a patient is having a leukoplakia, this can proceed into malignancy. Which type of malignancy? Squamous cell carcinoma. A patient who is having oral lichen planus can proceed into malignancy. Which malignancy? Squamous cell carcinoma. Remember Bowen's disease? Probably you learned in surgery as well. So if you get a Bowen's disease over the skin, this can proceed into which malignancy? Squamous cell carcinoma. A cutaneous horn can proceed into which malignancy? Squamous cell carcinoma. So the point here is maximum number of pre-malignant lesions are seen with squamous cell carcinoma. So about malignant melanoma, I would say that try to remember the basic characteristics. In this last minute, don't go into all the classification. Try to remember the basic characteristics of malignant melanoma. Yeah, very good. Mupin is adding one more thing. In the last FMG exam, this question was asked. What is the name of squamous cell carcinoma that arises from burns? Who can answer in the chat box? It was reminded by Mupin. What is it? Squamous cell carcinoma arising from burns. It is called as, very good, Marjolin's ulcer. It is called as Marjolin's ulcer. Okay, very good. Now let's go to the next one. Pre-malignant conditions of the skin include all of the following except acanthosis nigricans, leukoplakia, solar keratosis, Bowen's disease. Now this, I would say that's a little bit of tricky question because out of all these things, the most appropriate answer should be acanthosis nigricans. But please remember, acanthosis nigricans rarely is associated with malignancies. It is rarely associated with malignancies, but associating with malignancy and being a pre-malignant lesion is different. What is pre-malignant? You have a cutaneous horn. This itself becomes a malignancy. whereas this is going to be associated. Now let us say leukoplakia. There are types of leukoplakia. Just give me a minute, just logging in. Am I audible properly? Yeah. Yeah, not visible, Stuti, because I prefer to be invisible. One moment. I'm just sharing the screen. Just give me a minute. Yes. So yeah, again, as expected, I'm in Kerala. With rains comes the most often thing of power cuts as well. That is the reason. Shall I just keep my video off for some time? Because I'm just using my hotspot so that the session is not interrupted. I'll just restart my video once we have the connection. Okay. I hope it is audible for all of you. So if it is audible, let's continue. Now, in this question, what was happening is, yeah, we were talking about pre-malignant lesions. So remember, acanthosis nigricans is rarely associated with malignancy, whereas what is the most common association of leukoplakia? I told you, right, just now, what the malignancy that has more maximum number of pre-malignant lesions is squamous cell carcinoma. So this is all these three is associated with squamous cell carcinoma. Leukoplakia, whitish discoloration over the tongue, isn't it? Whereas solar keratosis is usually seen in elderly patients, farmers who had a lot of sun exposure, and they may develop skin malignancy. Bowen's disease is again a pre-malignant type of squamous cell carcinoma. Same concept is here. Now, when it comes to acanthosis nigricans, in acanthosis nigricans, what is happening? There is a velvety type hyperpigmentation, isn't it? Can you tell me what are the areas in our body where we can find acanthosis nigricans? Yeah, we can see it over the neck area. We can see it over the axilla, etc. That is where you can find acanthosis nigricans. The second thing is, what is the most common association of acanthosis nigricans? Can anybody say what is the most common association of acanthosis nigricans? Yeah. No, the answer, if you're saying it as diabetes mellitus, it may not be right. So you can better, the most common association is going to be obesity. Along with obesity, there can be diabetes, there can be PCOS, any other metabolic syndrome. But remember, most common association is going to be obesity. Okay? So now let's move to the next one. Just a minute. Should we continue without video or should we continue with video? Okay. Meanwhile, just solve this issue, solve this thing. I'll just okay, let's do this MCQ and then change to video. A neonate presents with persistent seizures and lesions on the face. Which of the following is true regarding this condition? Sturge-Weber syndrome is the most likely diagnosis. Image reveals port wine stain. CT brain will show tram track calcification, all of the above. ABCD. So most of the times when you get these kind of options like none of the above, all of the above, etc., more likely to be the right answer, correct? But don't take it for granted. Examiner can also be smart, isn't it? So please read all the options carefully, and then if you feel that multiple answers are correct, then go for all of the above. Now see this image. This can be a spot diagnosis for you. What is this lesion called as? It's called as the Portuguese wine has been spilled over the face. It's called as the port wine stain. Port wine stain, can you see that this does not cross the midline? So this is mostly does not cross the midline. It is commonly associated with a syndrome that is called as the Sturge-Weber syndrome. So when we talk about different types of vascular anomalies, what is the another vascular anomaly that you have learned? Yeah, so Rahul is saying about capillary hemangioma. So when it comes to capillary hemangioma, what is differentiating a capillary hemangioma from a port wine stain? So what usually differentiates is port wine stain is something that you can see like this, whereas capillary hemangioma is not that large. It is up to a size of a strawberry. That is why we may call it as strawberry hemangioma. But the point here is when it comes to port wine stain, we remember it as P for P. What is P for P? It is present since birth and it persists throughout life. It persists throughout life. So remember the two P. P for P, port wine stain, present since birth, persists throughout life, whereas capillary hemangioma is going to be called as strawberry hemangioma. Do we need to do any treatment for strawberry hemangioma? Is any treatment required for strawberry hemangioma? No. So strawberry does not require treatment. By what age does the strawberry regress? Remember, 50% by 5 years, 70% by 7 years, 90% by 9 years. So 90% regression by 9 years. So which means by 10 to 12 years of age, the entire strawberry is going to disappear. That is the important thing about strawberry. So now just do this MCQ. In the meanwhile, let me just try to turn on the camera. Yeah. Visible now? Yeah. Which are the following types of psoriasis? A history of streptococcal pharyngitis may be found. Flexural psoriasis, pustular psoriasis, gutted psoriasis, erythrodermic psoriasis. So this is a type of psoriasis which during our sessions I have told you that there is a type of psoriasis which is associated with an infection. What is the infection? The infection is streptococcal sore throat. Now, what is streptococcal sore throat? Group A, beta hemolytic streptococcus. This is usually associated with guttate psoriasis. It's usually associated with guttate psoriasis. Now, among all these four options of psoriasis, which is the rarest type of psoriasis? A, B, C, D. Same options, rarest. Any answer? Rarest type of psoriasis? Yes, this is the rarest type. So why is this the rarest type? The reason is rarest is flexural. Then what is the most common type of psoriasis? Most common type of psoriasis is called vulgaris. That is psoriasis vulgaris. And where will you find the lesions in psoriasis vulgaris? You can find the lesions here over the extensor. It is seen in the extensor. So this one is going to be more common over the extensor surfaces. Can anybody tell me what is the type of scaling that you can find in psoriasis? What is the type of scaling? Is it rice powder like scaling? Is it brownie scaling? Is it silvery white scaling? Yeah, so we can find silvery white scales when it comes to psoriasis. So remember, if you get any image where you get a plaque lesion, red color plaque lesion, along with whitish silvery white scales, this is going to be psoriasis. In which of the type of psoriasis can you see that 90% of the skin turns red in color? A, B, C, D? Same thing, A, B, C, D? Yeah, here more than 90% of the body surface area turns red. This is going to be red in color. Among all these options, which is considered to be a dermatological emergency? Yes, Mahesh, this is again considered to be a dermatological emergency. So why is this considered to be an dermatological emergency? What is the risk that is associated? Yeah, heart. What happens? High output, low output? Yeah, the patient can go into cardiac failure. The patient can go into high output cardiac failure. That is the reason why this is considered to be a dermatological emergency. Now, how many of you remember what are the types of pustular psoriasis? Psoriasis is an important topic. That is why I would like to give a couple of minutes more for this topic, because any FMG exam, psoriasis is one topic where the question is for sure, isn't it? Now, can anybody tell me what are the types of pustular psoriasis? What are the types of pustular psoriasis? Yeah, pustular psoriasis, it can be either localized or generalized. Pustular psoriasis, it can be either localized or generalized. And one last question is, if there is a pustular psoriasis, what is the type of pustules? Are these pustules filled with bacteria, or are these pustules going to be sterile? So remember, in both these cases, these are going to be sterile pustules. These are going to be sterile pustules. Very, very important thing when it comes to pustular psoriasis. In psoriasis, it is not associated with an infection. So these pustules are going to be sterile pustules. And what is the other name of pustular psoriasis, generalized pustular psoriasis? This one is called as the von Zombush reaction. It is called as the von Zombush reaction. Okay. So I'll just come back to the treatment part of psoriasis in a while. Now let's do one more MCQ in psoriasis. Before that, in psoriasis, nails are also affected, correct? So in the nail changes in psoriasis include pitting, pterygium, subungual hyperkeratosis, thinning of the nails, oil spots. See, remember in the NEET PG exam, as well as in the INI CET exam, this is the type of questions that were asked. Okay, multiple things. We have to add 1, 3, 5, 1, 3, 4, 5, etc. to the answer. So try to practice these kind of MCQ as well. So now try to answer, what do you find in nail finding in psoriasis? Do you find pitting? Yes or no? Let's go one by one. So do we find pitting? Yes. So this is the most common nail change in psoriasis, correct? Do you find pterygium? What do you mean by pterygium? There is a wing-shaped extension over the nails. So this is actually seen in which disease? Where do you find pterygium of the nails? Very good. We can find it in lichen planus. So this is not included. Subungual hyperkeratosis. There is a thickening beneath the nails. Can be seen or not? Yes. So this can also be seen. Thinning of the nails. Is it seen in psoriasis? In psoriasis, actually, the nails become thicker. Fine. So this is usually the most common nail change in some disease. In which disease is thinning of the nails very commonly seen? It is seen in lichen planus. Oil drop sign or oil spots. Is it seen or not? Yes. This is the most characteristic change. It's the most characteristic change. So now what are the answers? The two things that we have ruled out is option 2 and 4. So 1, 3 and 5. So what is the right answer? Option B. So option B is going to be the right answer. That is 1, 3 and 5. Yeah, we have learned it as poison, P for pitting, OI for oil drop, S for subungual hyperkeratosis, O for onycholysis, isn't it? N for nail plate dystrophy. So all these things are given it together. And coming to the treatment. So quickly answer some of the important treatment part of psoriasis. Very important. If any of you have not revised regarding the treatment part, let's do it now. Fine. Don't keep it for later. What is the overall drug of choice in psoriasis? So what is the overall drug of choice in psoriasis? Yes, in the chat box. Can all of you answer in the chat box, please? Because don't make this thing wrong. I want all of you to get this thing right if you get any question on the treatment. Yeah, this is going to be methotrexate. So what is the drug of choice in nail changes in psoriasis? Methotrexate. What is the drug of choice when there is scalp changes in psoriasis? Methotrexate. What is the drug of choice when you have joint pains in psoriasis? Methotrexate, isn't it? Overall drug of choice is going to be methotrexate. Now the difference is, what is the drug of choice in pustular psoriasis? So what is the drug of choice in pustular psoriasis? Very good. All of you are answering it as acitretin. Remember, there is some teratogenicity of acitretin. How long is the teratogenicity? Yeah, teratogenicity is going to be 3 years. So remember this very, very important side effect of acitretin. It is going to be 3 years. Now, what do you do when you get a pregnant female with psoriasis? Which means drug of choice of psoriasis in pregnancy. So what is your drug of choice here? Very good. Here it is going to be steroids. So steroids are going to be the drug of choice when it comes to pregnancy. So in pregnancy, psoriasis is also called by another name. There is one misnomer. Do you remember what is the misnomer for psoriasis in pregnancy? It is called as impetigo herpetiformis. It is called as impetigo herpetiformis. Okay? And then remember the most important sentence when it comes to the treatment of psoriasis, that oral steroids are contraindicated in psoriasis. Because when we learn dermatology, we learned that our most favorite drug in dermatology is a steroid. So if there is a large surface area, you give prednisolone tablets, dexamethasone, betamethasone, all these things which is taken orally is contraindicated in psoriasis. What will happen if you give steroids? What will happen if you give steroids? Can lead to, von Zombush reaction, which is also called as generalized pustular psoriasis. It is also called as the generalized pustular psoriasis. So I hope this concept is clear to all of you. So if yes, let's move further. A patient presents with asymptomatic erythematous scaly lesions over the extensor aspect of the elbows and knees. Bedside test useful in making the diagnosis. Now, before you go into all those options, see the question. What is the main thing here? Asymptomatic, no itching. There is a erythematous scaly lesion over the extensor surface. What did we learn just now which can be seen over the extensor surface? Yeah. So here, what is the most likely diagnosis? The most likely diagnosis once again is psoriasis. So in psoriasis, do you do a Auspitz, KOH, Zansmeer, skin biopsy? What is bedside test? So the bedside test which can be used for the management or which can be used for the diagnosis is called as a Auspitz sign. So do you remember what is an Auspitz sign? If you do a scraping of the skin lesion, you may find small bleeding spots. And this is called as Auspitz sign. This is also called as the Auspitz sign. So we take a glass slide, just do a scraping over the lesion. So once you do a scraping over the lesions, multiple pinpointed bleeding spots will appear. And this is called as Auspitz sign. Nice smiley, Pardeep. Chalo. Now tell me what is another phenomenon or one more clinical sign which can be seen in psoriasis? Who can answer? Starts with K. Very important one, asked in the last FMG exam. Very good. This is called as the Koebner phenomenon. Now what happens in a Koebner phenomenon? Anywhere there is a trauma, new lesions will appear. Now tell me 3 diseases where you can find Koebner phenomenon. There are 3 diseases where we can find Koebner. So quick revision. Don't tell me LGV, it is LVP. So LVP is lichen planus, V for vitiligo, and P for psoriasis. So these 3 conditions will show you a Koebner phenomenon. So when we learn about Koebner, let us learn about or revise about pseudo Koebner as well. So where do you find a pseudo Koebner? Please remember, very, very important. Okay, where do you find pseudo Koebner? What happens in pseudo Koebner is new lesions arise because of auto-inoculation of the virus. So what is the answer? It's seen in viral infections. Anyone? No, none of you are answering. Not fine. Okay, I got one right answer. Anyone else? Only there is a right answer from Stuti. How about others? Pseudo Koebner phenomenon. Yeah, this can be seen in Molluscum contagiosum. It can be seen in viral warts, human papilloma virus. Okay, so please remember Koebner's phenomenon, pseudo Koebner. Pseudo Koebner associated with viral infection. That is why when we touch one lesion and then touch the adjacent skin, the virus gets auto-inoculated from one side to the other. Multiple lesions develop, like in warts, like in Molluscum contagiosum. Moving to another very, very important topic in dermatology, which can be expected is Buller's diseases. Now, see this question. Pemphigus foliaceus, the split occurs in which layer? All of you still active? Are you tired after the orthopedics test and discussion, then dermatology? 2 TNDs in a day? try to stretch a bit. Take it. So now let's see pemphigus foliaceus split occurs in which layer? Subcorneal, spinosum, derma epidermal junction, suprabasal. Yeah. So pemphigus foliaceus, if you remember, that is the most superficial type of bulla, and that can be seen when it comes to pemphigus foliaceus. Remember, when we learn about vesiculobullous diseases, we can divide vesiculobullous diseases where there is a intraepidermal split or a subepidermal split or a subepidermal split. Now, when there is a split within the epidermis, this can be either pemphigus foliaceus or it can be pemphigus vulgaris. Whereas, can you name what is a disease when it comes to a subepidermal split? When there is a split below the epidermis, what is the name of the disease? Yes, Abhishek, it is called as bullous pemphigoid. It is called as the bullous pemphigoid. Now, another difference is when it comes to vesiculobullous diseases, the defect is also something different. What is the defect in pemphigus foliaceus? Which type of desmoglein? Options are desmoglein 1, desmoglein 3, desmoglein 3 and 1. What is it? Yeah, so in pemphigus foliaceus, there is a defect of desmoglein 1. Whereas in pemphigus vulgaris, there are two defects. What is that? Desmoglein 3 followed by desmoglein 1. Fine. And what is the defect in bullous pemphigoid? Bullous pemphigoid. The name itself, remember, bullous pemphigoid, BP. So BPAG2 and BPAG1 is going to be the defect in bullous pemphigoid. Okay, so whenever you get any question about vesiculobullous diseases, try to see if it is an intraepidermal split or a subepidermal split. So if there is an intraepidermal split, is it going to be more superficial or which is going to be more superficial? This one or this one? Which is more superficial? Yeah, superficial is going to be intraepidermal. So what is the type of bulla when it comes to intraepidermal blistering diseases? Is it a flaccid bulla or is it a tense bulla? Flaccid or tensed? Yeah, this is going to be flaccid. And when the bulla is forming below the epidermis, it is much more deeper. That is why we will be seeing a tense bulla. So we can find a tense bulla. Remember? So all these are some of the important concepts, the basics. And once you go back to your workbook, please try to go through those tables that we have discussed during the discussion of the classes. Fine. And let us see one more question from the same topic, that a direct immunofluorescence from a blistering skin is seen below. Histology showed suprabasal blister. What is your diagnosis? Anyone? So what you can see is an image of a direct immunofluorescence. Now in the question there is a hint that this is a disease with suprabasal blister. What is suprabasal? Suprabasal means above stratum basale. What is a layer above stratum basale? That is stratum spinosum. So in which disease do we get a bulla in the stratum spinosum? Just see the options now. Foliaceus, bullous pemphigoid, dermatitis herpetiformis, pemphigus vulgaris. Yeah, that is in pemphigus vulgaris. Now, please concentrate here. Over the last two exams, especially the INI-CET as well as the NEET PG, they were asking you simple concepts regarding the direct immunofluorescence. So just to be prepared with this investigation. So in INI-CET, very easy question was asked. What is the investigation that you use to diagnose skin diseases. Options were indirect immunofluorescence, direct immunofluorescence, something else. Okay, the answer is always direct immunofluorescence when it comes to skin diseases. Now, in direct immunofluorescence, in intraepidermal diseases, like we learned about pemphigus foliaceus, pemphigus vulgaris, etc., there is a common pattern. What is a common pattern? This is called as the chicken wire pattern, or it is also called as one more name, fishnet pattern. Whereas when the disease is below the epidermis, we cannot see this chicken wire pattern or a fishnet pattern. So in subepidermal diseases, we usually see a linear pattern. Can anybody tell me where do we find this linear pattern? Do we see the linear pattern in the dermis? Do we see the linear pattern in the stratum basale? Or do we see a linear pattern over the dermo-epidermal junction? Where do we find this linear pattern? Yes, in the dermo-epidermal junction. Well, there is one more name for the dermo-epidermal junction, because in the exam they can give you any of the names. So dermo-epidermal junction is also called as, anyone starts with B, basement membrane zone. Okay, in the basement membrane zone. So that is about this MCQ. So this image is the fishnet pattern or the chicken wire pattern, which you can see within the epidermis. It is usually seen in either pemphigus foliaceus or pemphigus vulgaris. In this MCQ, why is the answer pemphigus vulgaris? Reason is, question says suprabasal blister. So in stratum spinosum, the blister is seen in pemphigus vulgaris. Now, last one more question before we go to the next MCQ. Vesiculobullous disease starting in the oral mucosa. Can you give me the answer? Patient presents with vesiculobullous lesions over the trunk. Patient says lesions began in the oral cavity. What is the answer here? Lesions began in the oral cavity. Mahesh is getting it right. How about others? Always remember pemphigus vulgaris always begins in the oral mucosa, and only after oral mucosa. So after oral mucosa, only the skin is going to be involved. Only pemphigus seen earlier, pemphigus in ocean. Yes, Pardeep. In all types of pemphigus, you get a fishnet pattern. Pemphigus foliaceus, pemphigus vulgaris, all these pemphigus, you get a fishnet pattern. Now, in vegetans, you get oral mucosal lesion. But I was like, starting in the oral mucosa, later skin is also affected, is always going to be pemphigus vulgaris. Okay, Stuti? So now let's go to the next one. A pregnant woman in the 7th month presented with a tense bulla and itching. The most common site of involvement. Actually, it's very easy. Image is also given. Where is the most common site of involvement? You can see the bulla mostly around. So where do you find this bulla? Yeah, umbilical. So what is the diagnosis here? The diagnosis here is going to be pemphigoid gestationis. Pemphigoid gestationis. So what is pemphigoid gestationis? This is bullous pemphigoid. The name itself, okay, pemphigoid. So this is going to be bullous pemphigoid in pregnancy. So here, okay, do we expect a flaccid bulla or a tense bulla? The name, pemphigoid gestationis. So what do you expect here? You expect a tense bulla. So if it is a tense bulla, what is going to be the defect? Is it desmoglein defect or is it BPAG2 defect? Yeah, this is going to be BPAG2 defect. Is going to be a BPAG2 defect. And this disease can also be confusing for you when it comes to exam if they give you the another name. What is a misnomer here? This is also called herpes gestationis. So this is also called as herpes gestationis. So remember, herpes gestationis is not herpes simplex virus infection in pregnancy. What is herpes gestationis? It is bullous pemphigoid in pregnancy. Okay? Next one, disc keratosis is a feature of. So during our sessions, I always used to tell you D4D. Remember, disc keratosis is seen in which disease? Darier's disease. So disc keratosis is seen in Darier's disease. What do you mean by disc keratosis? Disc keratosis means defective keratinization of the skin. So defective keratinization is seen in Darier's disease. So there is one sign which we learn in dermatology by the name Darrier sign. So while we learn Darier's disease, remember Darrier sign also. So remember, Darrier sign is not seen in Darrier disease. Then where do you find a Darrier sign? Can anybody answer in the chat box? Yes, Pardeep is answering it right. Anyone else would like to give it a try in the chat box? Darrier sign is seen in. This is seen in Urticaria pigmentosa. It is seen in Urticaria pigmentosa. Okay, remember, in Urticaria pigmentosa, we find Darrier sign. Darrier's disease is a vesiculobullous disease. It is an inherited disease, autosomal dominantly inherited. This is where you find disc keratosis as well. This is where you find disc keratosis as well. So next one is, what is the ratio of epidermal melanin unit? 10 keratinocytes, 1 melanocyte, 26:1, 36:1, 36:2. Any answer? Yeah. So I think this is a direct question, 36:1, which means that for every melanocyte, there is going to be 36 keratinocytes. Is there any significance of this ratio? For every melanocyte, it supplies melanin pigment to 36 keratinocytes. What is the significance of this ratio? Yeah, Akanksha is answering. So this is the reason why we have a uniform skin color. There is a reason why we have a uniform skin color. So this number is fixed in all of us. In me, it's 1:36. In you, it's 1:36. So when you check the entire skin, we have a same skin color throughout our body because of this common ratio. Okay, remember 1:36. How about this one? A 35-year-old woman presents with a light brown patch over the cheeks since the past 5 years. What's the diagnosis? Very good. So most of you are getting it right. If anybody is answering it as freckles, it is wrong. So this one is going to be melasma. Why melasma, not freckles? Why melasma, not freckles? Who can answer? See the image? Melasma usually presents as a brownish colored patch. Patch is a larger lesion. So when it comes to freckles, it is usually brownish macules. Okay. In freckles, it is usually going to be brownish macules. That is why here the right answer is melasma. Quickly tell me, what are the causes of melasma? Causes of melasma in the chat box, please. Yeah, one is sun damage. So remember, whoever is not using sunscreens may end up developing melasma in the middle age. Another reason for melasma is, no, it is going to be hormonal. It is going to be hormonal. So hormonal changes, it can be due to any endocrinological disease. It can be due to diabetes. It can be due to hypothyroidism, isn't it? So there is a hormonal reversal which happens in a disease called polycystic ovarian syndrome, PCOS, isn't it? There is a hormonal change that happens during pregnancy. So all these are the causes of melasma. What do you call for melasma in pregnancy? Melasma that appears during pregnancy because of hormonal changes. Yeah, very good. It is called as cloasma. It is mentioned as the mask of pregnancy. And finally, when it comes to the treatment of melasma, what is the drug of choice in melasma? Yes, Abhishek is answering it correct. Anyone else who would like to answer it right? Yeah, Pardeep, Mupin, all of you are answering. It is going to be hydroquinone. So hydroquinone is going to be the drug of choice in melasma. So don't forget, on the day of exam, you get an image like this, large brown color patch, melasma. Smaller brown color macules is always going to be freckles. It's always going to be freckles. Next question. A 22-year-old male developed pigmentation over the upper chest for the last years as shown in the image. What's the diagnosis? Yes. So here you can find that there is a brownish discoloration over the chest area. So over the chest or over the shoulders, this is usually seen in association with Becker's nevus. So this is not drug reaction because the question does not say anything about a drug usage. Post-inflammatory hyperpigmentation, again, question does not say you a history of any type of a inflammatory reaction. Congenital melanocytic nevus, what should be the color of a congenital melanocytic nevus? Color, blue, red, black, yellow. What is going to be the color of congenital melanocytic nevus? It is always going to be black. So here this image is more likely to be Becker's nevus. In Becker's nevus, you get a brownish hyperpigmentation. One more finding in Becker's nevus. See the image and you can answer, or you can memorize an answer. What is it? Yeah, hypertrichosis. Hypertrichosis means increased hair growth at the site of the lesion. It's called as hypertrichosis. So all these are going to be called as Becker's nevus. Next one, a patient presented with a unilateral depigmented lesion on the neck and chin associated with leukotrichia. Diagnosis. Give your answers in the chat box. So yeah, I think most of you are getting it right. Yeah, correct. So this is going to be segmental vitiligo. Now just come back to the question, what are the features described in this MCQ that is in favor of segmental vitiligo? Yeah, Mahesh says does not cross the midline. It is a unilateral lesion. And it is not hypopigmented, it is depigmented. That is also one of the keyword. Depigmented because there is complete absence of melanocytes. Whenever there is a complete absence of a melanocyte, we call it as a depigmented lesion, not a hypopigmented lesion. And it is seen over the neck and chin area. So there may be some whitish discoloration of the hair that is associated with a bad prognosis. So the right answer is segmental vitiligo, which is going to be along a dermatome. So since it is along a dermatome, that is the reason why the lesions do not cross the midline. So okay, lesions do not cross the midline. So when it comes to vitiligo, what is the drug of choice in vitiligo? Do you remember? Yeah, it is going to be tacrolimus or pimecrolimus. So remember, tacrolimus or pimecrolimus is going to be the drug of choice when it comes to vitiligo. What are the other treatment modalities that we can use? Other treatments? Yeah, this can be phototherapy can be used, and steroids, very good. Steroids can also be used. Okay, because why? What type of disease is vitiligo? Is it inherited through some genetic defects or something else? What is the type of disease? Vitiligo, remember, it is a autoimmune disease. So can a patient of Hashimoto thyroiditis develop vitiligo? Hashimoto thyroiditis develop vitiligo? Remember, yes, autoimmune diseases tend to occur together. That is why Hashimoto thyroiditis and vitiligo can be seen together, or any other autoimmune diseases can be seen along with vitiligo. Next one. A 30-year-old male presents with a skin lesion over the body 1 week after taking NSAIDs. See, just when you repeatedly practice MCQs, when you read one MCQ after the other, you are getting it. Like every time there is age, keep age in your mind, 30-year-old. There is a skin lesion. But says 1 week after taking a drug, which means drug reaction, correct? Now check the options. Psoriasis is not associated with a drug reaction. Erythema multiforme can be associated with drugs. Fixed drug eruption can be associated with drugs. Stevens-Johnson can also be associated with drug. But see this image and what is the most likely diagnosis? Hyperpigmented macule is associated with fixed drug eruption. Now, let us differentiate all these things. How do you see erythema multiforme? Erythema multiforme, you can see something like this. Can you tell me what is this lesion called? Erythema multiforme looks like this. It's called as target lesion. One more name in the chat box. Very good. Bullseye. One more name. Target and bullseye has already come in the chat box. One more name for this lesion. This is iris lesion. Okay, this is iris lesion. So these can be seen in erythema multiforme. This can be seen in erythema multiforme. The another one is fixed drug eruption, which we have spoken. After you take any drug, if you develop a hyperpigmented macule or a patch, this is more likely to be fixed drug eruption. Anything about Stevens-Johnson syndrome? Stevens-Johnson syndrome. So what happens in Stevens-Johnson syndrome? Stevens-Johnson syndrome and toxic epidermal necrolysis, they tend to occur together. Now, what is happening in Stevens-Johnson and toxic epidermal necrolysis? There is massive peeling of the skin along with involvement of at least 2 mucosa. Along with involvement of at least 2 mucosa. So that is what you call as Stevens-Johnson syndrome. It looks like skin is peeling off after taking a drug. Then you can think about Stevens-Johnson syndrome or toxic epidermal necrolysis. So do you need a short break or continue? Because somebody was asking for break. That's what I'm. Okay, continue. Sure, take it. So now let's see this one. A 40-year-old male came with a history of fever, malaise, skin peeling. So as usual, let's go in the same pattern. Let's keep 40 in our mind. And with the history of fever, malaise, peeling of the skin, painful oral ulcer for the last 3 days. On examination, there was extensive skin peeling in sheets, skin tenderness, along with hemorrhagic crusting on the lips. Now, can you give the diagnosis now? Same MCQ in a different way, correct? Is it staphylococcal scalded skin syndrome, toxic epidermal necrolysis, Stevens-Johnson syndrome, or pemphigus vulgaris? Okay, I'm getting all the answers, but many of you are getting it right. This can be toxic epidermal necrolysis. Now let us see how do we differentiate all of these. Staphylococcal scalded skin syndrome. massive peeling of the skin can be seen, and there will be no mucosal involvement. Okay, there will be no mucosal involvement. And usually this is seen in children. So if the MCQ is a child, okay, if the MCQ is a child with massive peeling of the skin, oral mucosa, genital mucosa, all normal. Think about staphylococcal scalded skin syndrome. Now, how do you differentiate Stevens-Johnson syndrome with toxic epidermal necrolysis? Both has the same presentation. Massive peeling, like massive peeling, mucosal involvement. Both are seen in Stevens-Johnson as well as toxic epidermal necrolysis. The differentiation happens according to the body surface area involved. So if it is less than 10% body surface area, Stevens-Johnson. If there is more than 30% body surface area, it is called as toxic epidermal necrolysis. Now just come back to the same MCQ. See why our answer is toxic epidermal necrolysis. Because the question is saying there is extensive skin involved. Most probably more than 30%. And there is an involvement of the oral mucosa as well. So based on all these features, the right answer should be toxic epidermal necrolysis. Okay, image was also given. Okay, fine. So in this PPT, probably we could not use it. No, for the overlap, it is less likely. See, clinically, Ashwin, when we go into practice, it is difficult to diagnose those overlap cases. But at least for the sake of your exam, for exams, what they will do is either they'll say that only a part of the skin is involved, less than 10% body surface area, or they'll give you extensive involvement. Fine. So a patient with fever, photosensitivity, rash, sparing nasolabial fold. Easy question, right? So again, this thing is one of the repeated questions for your exam. So whenever you get a patient with photosensitivity, aphthous ulcers, etc., with a butterfly rash, the correct answer should be systemic lupus erythematosus. How do you expect a patient of dermatomyositis? Dermatomyositis can have skin manifestations as well as muscle manifestations like weakness of the muscle, etc. In the skin, can you name few skin manifestations of dermatomyositis in the chat box quickly? What is the color of the skin? Let me ask you. Color of the skin in dermatomyositis? Yes, heliotropic rash or purple colored rash. Is there anything that you can see in dermatomyositis over the hands, over the knuckles, over all the joints? What do you call for that? Those papules. So these are called as Gottron's papules. Very good. Gottron's papules can be seen. So Gottron's papules along with the purple colored rash, especially over the eyelids or over the face, is going to be dermatomyositis. Along with that, there can be a photosensitive rash as well. So these photosensitive rashes can be called as shawl sign or V-shaped erythema. V-shaped erythema, etc. That is about dermatomyositis. All of us have dealt with melasma because that is brownish hyperpigmented patch. How about rosacea? Anyone? So rosacea is something we haven't touched till now. So what happens in rosacea? Yeah. So rosacea means this is usually a middle-aged patient with a red face. Along with red face, there is one more complaint. It is called as flushing. And when will a patient of rosacea complain of flushing? Is it when he drinks something cold? Is it when he goes to the sun or something else? Yeah. So this flushing is usually seen when the patient takes spicy food or hot beverage or alcohol. So when you get this kind of a clinical scenario, then think about rosacea. There would be a red colored face along with flushing that is associated with spicy food, hot beverages or alcohol. What is the type of rosacea which requires a surgical management? Yeah, nasolabial fold usually is involved when it comes to rosacea. So rosacea requiring surgical management is what you must have learned in ENT. It's called as rhinophyma. Okay, rhinophyma. Okay, potato nose. So that is the type of rosacea which requires surgical treatment or laser therapy. It's called as rhinophyma. Now see this one. Again, it's a repeat question. This is what I have explained few minutes ago. The following finding is seen in. What do you see in this finding? You can see that there is a reddish discoloration over the joints. Okay, in between the joints, it looks normal. So what is it called? Ashwin, that is not rhinophyma, it's phrynoderma. Okay, associated with vitamin deficiencies and all. Okay, so this one is Gottran's papules. And we discussed about it. This is seen in dermatomyositis. It is seen in dermatomyositis. The microorganism that is associated with seborrheic dermatitis. Commonly, what do we call for seborrheic dermatitis? All of us, or else most of us have this problem. It's called as the dandruff. So in dandruff or seborrheic dermatitis, what is the microorganism? Microsporum, Streptococcus, Corynebacterium, Malassezia. Direct question, Malassezia. Okay. So this Malassezia furfur is a usual organism that is implicated in the pathogenesis of seborrheic dermatitis. Now, what is the treatment that we can give for this Malassezia furfur? So the treatment of Malassezia furfur can be azole group of drugs. Okay, so azole group like your fluconazole, isn't it? All the azole group, ketoconazole, all these things can be used. Along with that, selenium sulfide can also be used. Now, when it comes to Malassezia, remember that there are two diseases caused by Malassezia furfur. Now, name the two diseases that is caused due to Malassezia. One, all of you know right now, this is going to be seborrheic dermatitis. What is the other disease? Yes, very good. Some more people to answer the chat box. Very good. It is called as the tinea versicolor. It is called as a tinea versicolor. So in tinea versicolor, it is again a fungal infection, versicolor, which means two different colors. Skin can be hyperpigmented or the skin can be hypopigmented. Now here, what can you expect for your exam is Malassezia furfur. If you do a KOH test, so in the KOH, what can you find? Yeah, this is called as the spaghetti and meatball appearance. So spaghetti and meatball appearance, banana and grapes kind of appearance can be seen with Malassezia furfur, which can be seen in seborrheic dermatitis or in tinea versicolor Next one, patient presents with itchy lesions as shown. The causative organism is most likely to be. Now, when you see these kind of images, what is the shape of the lesion? The shape is annular. Where do you find the scaling in this lesion? See the image? You see scaling in the entire lesion or more towards the periphery. Where do you find scaling? Yeah, you can find peripheral scaling. So where do you find annular lesion, peripheral scaling, etc.? This can be seen in tinea corporis or ringworm So in the beginning of the discussion, we were talking about tinea corporis. So what is a causative organism? Is it caused due to Sporothrix shenkai? Is it caused due to Mycobacterium leprae, Trichophyton rubrum, or Candida albicans? Yeah, Trichophyton rubrum. So remember, this is the most common causative organism in dermatophytosis. Okay, in dermatophytosis, like Tinea cruris, Tinea corporis, Tinea pedis, etc. The most common organism causing infection is Trichophyton rubrum. Trichophyton rubrum. I hope all of you remember we discussed about the drug of choice. What is the drug of choice? I'm not writing it anymore. Drug of choice, tinea corporis, terbinafine. Just one point, because what was asked in previous FMG exam. What is the treatment of steroid modified tinea? What is the treatment of steroid modified tinea? Matlab, if there is a fungal infection, you are treating it with steroid creams. Will the fungus die? No. Will the inflammation go down? Yes, because steroids has anti-inflammatory effect, correct? So what do you call for this and what is the treatment? So this is called as tinea. Anyone in the chat box? Very good, Pardeep. Stuti is also answering it right. Anyone else? So this is called as tinea incognito. It was asked in the previous FMG exam. So if you treat fungal infection with steroids, it's called tinea incognito. So that is not the right management. What is the right management of tinea incognito? Stop steroids and start antifungals. So that is going to be tinea incognito. So now let's see this one. A 8-year-old boy presents with a painful swelling over the scalp and gives a history of having a pet dog at home. Once again, today when we started the discussion, I said that whenever you find something over the scalp, if it is child, then what is your first differential diagnosis? First differential diagnosis should be a fungal infection. Which fungal infection is more likely? Based on this presentation, this is most likely to be Chirion. It's got more likely to be Chirion. So in this Chirion, there is usually a history of a contact with a domestic pet at home. One of the important points in Chirion that you can remember is Chirion can lead to scarring alopecia. Chirion can lead to scarring alopecia as well. So this is a typical presentation, a tender, boggy swelling, and there may be a painless loss of hair, okay, or easily pluckable hair. There can be a lymphadenopathy, but most important finding is scarring alopecia. Yes, with any pet animal, it can be associated with cats, it can be associated with dogs, because this fungus is usually transmitted to humans through cats or dogs. That is the usual thing, Pardeep. Now here, I just want to add on some of the causes of scarring alopecia. All of you, can you just type down some of the causes of scarring alopecia? One is Chirion. Another cause, give it a try. Quick, we cannot slow down the pace of the session. Favors can also cause in sometimes. I agree. Another one. One of the answer is there in the MCQ itself. Furuncle Chirion dissecting cellulitis abscess. What else can cause scarring alopecia? Dissecting cellulitis. One question is, can lichen planus cause scarring alopecia? So remember, lichen planus of the scalp can also cause scarring alopecia. And which type of lupus erythematosus can cause scarring alopecia? Lupus erythematosus. Very good, Gayatri. So this is going to be discoid lupus erythematosus. So remember, all these are examples of scarring alopecia. And everything else that is usually which starts with either A or T is now going to be a cause of non-scarring alopecia. Anything that starts with A or anything that starts with T is usually an example of non-scarring alopecia. So just flow in the types of non-scarring alopecia. A and T. Starts with A, starts with T. Can you please give those examples in the chat box? Come on, quick. 7:30. Even you need to prepare for tomorrow. Androgenic alopecia, very good. Alopecia areata, very good. Anything that starts with T, trichotillomania, very good. Tinea capitis, okay, because some of the tinea capitis may have this one. Traction alopecia, very good. Telogen effluvium, very good. Anagen effluvium. So anything that starts with A or T is usually non-scarring. And scarring alopecia, chirion, dissecting cellulitis, lichen planus, GLE. Keep all these things in your mind. Next one. Cauliflower-like lesions. Hannah, in the image. Now see the question. Farmer with these lesions. What is the diagnosis? This is already discussed. Cauliflower-like lesions in a farmer is going to be chromoblastomycosis. I also told you what is the histopathological findings. Remember? Quick revision. Yeah, copper penny bodies. So other than copper penny bodies, what are the other names of copper penny? Sclerotic bodies, medlar bodies, or muriform cells, or muriform bodies. So all these are the other names of chromoblastomycosis. Why is this name chromo? Chromoblastomycosis. Chrome means color. So what is the causative, which is actually a pigmented fungus? It's a pigmented fungus. Bonus question, anyone who can answer in the chat box, name of the causative of chromoblastomycosis, which is a pigmented fungus. It's called, starts with F, Fonsesia pedrosi. Okay, it's called as the Fonsesia pedrosi. That's the pigmented fungus. It's a pigmented fungus. Next one. A patient presented to the dermatological OPD with a painless ulcer over the glands with bilateral, exactly, making things complicated for us, especially for exams. Because Vardhi was asking why so many names given for the same thing. Anyways, coming back, painless ulcer, bilateral painless lymphadenopathy. And he had a unprotected intercourse a month ago. What is the best next step? Azithromycin, gram stain for the confirmation of diagnosis, dark field microscopy, test to rule out HIV. So some of you are saying A, some of you are saying C. Now, all of you please concentrate here for a minute. Whenever you get any question about genital ulcers, there is two major things that you will look for. The first major thing that you look for is whether it is a painful ulcer or a painless ulcer. And please try to remember painless ulcer by this mnemonic LSD. Okay, LSD is a drug. So if there is a drug, you will not get to know the pain. So L can be LGV, syphilis, donovanosis. Okay, syphilis, LGV, syphilis, donovanosis. The second point here is always we have to look for the characteristics of the lymphadenopathy also. characteristics of lymphadenopathy also. So now let me quickly write down some of the characteristics of the genital ulcer. I would say that this is a very, very important thing that you have to revise for your exams before you go for the FMG exam this time. Very, very likely page of question. So write down the answer for all these questions. Okay. Okay. So the first one is painless ulcer plus painless lymphadenopathy. What is the answer here? Painless ulcer, painless lymphadenopathy. Both are painless. Silent disease. Answer is syphilis. Okay, answer is syphilis. Second one, painless ulcer, painful lymphadenopathy. Who can answer this one? Painless ulcer, painful lymphadenopathy. Should be one among these three. है ना? Yeah. So this is going to be LGV. LGV. Next one is painless ulcer plus no lymph node involvement. No lymphadenopathy, no venosus, no lymph node involvement. So this is donovenosus. Okay. What is the color of a donovenosus ulcer? The color also can be a catch for you. This is beefy red in color. And it bleeds to touch as well. Okay, it bleeds to touch. The next one is painful multiple ulcer plus painful lymphadenopathy. Both are painful. Ulcer is also painful and lymphadenopathy is also painful. Who can answer this one? Yeah. So this can be chancroid. This can be chancroid. But this can also be herpes genitalis also. This can be herpes genitalis also. So please have this. Multiple ulcers, painful ulcer, painful lymphadenopathy can be either chancroid or it can be either herpes genitalis also. Now the question is, how do we differentiate these? So these can be differentiated because based on buboes. Because in chancroid, you get buboes, whereas there is no buboes in herpes. There is no buboes in herpes. Fine. Very good. So please try to remember this thing so that you have an idea about how do you diagnose and manage genital ulcers. Okay, genital ulcers. Now coming back, see this MCQ, painless ulcer, painless lymphadenopathy. Tell me what is the diagnosis in this MCQ? Painless ulcer, painless lymphadenopathy. Diagnosis? Yeah. So here this is syphilis. And in syphilis, how do you diagnose syphilis? Will you simply give azithromycin? Will you go for gram stain? Will you go for dark field microscopy? Or will you do a HIV screening test? Yeah, syphilis is diagnosed by dark field microscopy. That is the right answer in this MCQ. Clear? And please make sure you go through all these options. Okay? Try to learn conceptually so that you will not make any mistakes. In dark field microscopy of syphilis, what you can find is the corkscrew motility of Treponema pallidum. So moving to the next question. Patient presents with an asymptomatic rash over the body with palmoplantar lesions. What can be seen during genital examination? Now, this is one of the previous questions that was asked in your FMG exam, because what you find in this image, you can see that there are multiple hyperpigmented rashes over the palms and soles. So that is all about the break in this test and discussions. So hope all of you are back. Let's continue. Okay. So here, I hope I'm audible. Yeah. So now let's see. A patient is presenting with a symptomatic rash. So what is this? Here the diagnosis is going to be secondary syphilis, isn't it? Secondary syphilis. In secondary syphilis, what can be expected? Acuminata, lata, Buschke-Lowenstein tumor, Sersinian balanitis. Yeah, so that is going to be condyloma lata. Remember, I told you earlier during the discussion. Now remember, in syphilis is one of the genital ulcer disease where you can get systemic symptoms as well as multiple other skin symptoms as well. Okay, multiple other skin symptoms as well. Moving to the next one. Which of the following types of syphilis is non-infectious? Did you do syphilis somewhere else, like in medicine or other subjects? So if yes, please try to answer this question. Where do you find syphilis which is non-infective? Primary syphilis. So now let's go one by one. Primary syphilis definitely is infective. The patient is having genital ulcer. He goes into intercourse with someone and then they may also get the primary syphilis, correct? So this is not the right answer. Secondary syphilis. Yeah, in secondary syphilis, what happens? Condyloma lata and all itself is very, very infectious. So this is also not the right answer. Now, how about early latent syphilis or tertiary syphilis? What is the right answer here? Yeah. So here the right answer should be tertiary syphilis because this is a stage of complications. This is a stage of complications. Usually by this time, what happens? The patient becomes non-infective. And the patient not only becomes non-infective, the patient is also having some systemic symptoms of other organs. Which are the organs that is involved in the complication? Both starts with C. What is it? It is going to be CVS and the CNS. The CVS and CNS. Yeah. So now another thing is that what happens in latent syphilis? In latent syphilis, there is no symptoms during latent syphilis. Only there would be circulating antibodies in the blood. Okay. So which is a stage of syphilis where the patient does not have any symptoms? Answer is going to be latent syphilis. Latent syphilis, where you will only find circulating antibodies, whereas you will not find any kind of symptoms. Now, there is one triad which is very important when we learn about syphilis. So now let's do this triad which is seen in congenital syphilis. So what do you find in late congenital syphilis? Or what is a triad that is important for your exams? Yeah, this is called as the Hutchinson triad. Now, what are the three features of Hutchinson triad? Hutchinson triad can be remembered as SIN. Anybody for S? Sensory neural hearing loss. What is I? Something that affects the eyes. I for eyes. Yeah, interstitial keratitis. Interstitial keratitis. Yeah. And then what is the last one? The last one is going to be notching of central incisor teeth. Of central incisor teeth. So these are the triad of late congenital syphilis. Okay? Moving to the next one. True about chancroid is painless ulcer, solitary ulcer, kissing ulcers can be present. Doxycycline is a drug of choice. A, B, C, D. Yeah. Kissing ulcers can be present. So in chancroid, all of you know that the patient may have painful ulcer as well as a painful lymphadenopathy, isn't it? So here the kissing ulcers can be present. It is not painless. It is not solitary. And is doxycycline the drug of choice or something else? What? Pradeep, it means that multiple ulcers very close to each other. Okay. And What is the drug of choice when it comes to chancroid? The drug of choice is going to be azithromycin. Azithromycin is going to be the drug of choice. Which of the following is not considered as a sexually transmitted infection? Syphilis, bacterial vaginosis, gonorrhea, chancroid. This is a high yield topic. I would say that sexually transmitted infections always asked. Please learn genital ulcer disease. Pakka 100% it's gonna come. Okay, very good. Most of you are answering it as bacterial vaginosis. Syphilis can be sexually transmitted. In gonorrhea, what is usually the presentation in gonorrhea? Gonococcal infections, what is the usual presentation? Is it ulcer or discharge? So remember, syphilis is going to be genital ulcer. Chancroid is also going to be genital ulcer. In gonorrhea, this is going to be discharge. What type of discharge? Purulent discharge. Okay, you get pus-filled discharge from the genitalia. That is usually the presentation when it comes to gonorrhea. Whereas, what is bacterial vaginosis? It is also a genital discharge disease, isn't it? This is also genital discharge. Genital discharge. Now, what happens in bacterial vaginosis? Bacterial vaginosis, how is the usual presentation? You get a scanty white discharge. You get a scanty white discharge. And is it foul smelling? Does it have a fishy odor? Yes. So this also has a fishy odor. Or let us say it is going to be foul smelling. But remember, this is not associated with as a sexually transmitted infection, even though this is more common in young females or sexually active females. Okay, so all these has different meanings. And what are the types of cells? Yeah, already it is there in the chat box. You can also find clue cells. Okay, clue cells. And what is the criteria? Amsel's criteria can be used for the diagnosis, isn't it? So that is about, yeah, that is all about genital discharge disease. Now let's see the next question. The following is seen in chronic urticaria, angioedema, pressure from a metallic object, atopic dermatitis. The most weird option here is pressure from metallic object. Somebody hit you and do you get these kind of marks? No, right? So what is this? Very good. Answer me, is it chronic urticaria or angioedema? Anyway, we have ruled out this one. Yeah. So this kind of lesions that you see over the skin is called as dermographism. Okay, dermographism. Try to remember at least two types of dermographism. One is red dermographism, where the skin becomes red in color. The other is white dermographism. The other is white dermographism. Okay. So where do you find red dermographism? Red dermographism is seen in chronic urticaria. White dermographism is seen in atopic dermatitis. It is seen in atopic dermatitis. Okay? So what is the answer here? White color, isn't it? So when the skin turns white in color, this is going to be seen in atopic dermatitis. Yes, somebody was mentioning, Abhishek is mentioning black dermographism is seen in nickel dermatitis, correct? And just right now when we are learning the most common ones, nickel dermatitis is less common. So here remember red dermographism, chronic urticaria, white dermographism, atopic dermatitis. Patient presents with multiple skin lesions as shown. Mother and brother is also having the same disease. What is not true about this disease? Before we go into what is not true, tell me what is the diagnosis. Spot diagnosis, you see a patient, multiple nodules over the face. So what is this? Yeah, this is going to be neurofibromatosis. Neurofibromatosis. And neurofibromatosis, it is a genetic disease. That is why mother and brother is also having disease. How will somebody get neurofibromatosis? Is it X-linked? Is it autosomal dominant? Is it autosomal recessive? Yeah, this is autosomal dominant in inheritance. Okay. So, sorry, I don't know what is number 40. I have not numbered the questions. Okay, RX. So now let's see this question. Café au lait macules are the earliest findings. Axillary freckles are pathognomic. Skin swellings due to collagenomas. Pseudoarthrosis of long bones. What is the wrong answer? Yes. So these skin findings or the swellings that you see within the skin is not due to any collagenomas. So here that is going to be the wrong one, because what is the most pathognomic sign? Axillary freckles. This axillary freckles is also called by another sign. Anybody? Anyone? So this is also called as the Grove sign. So the axillary freckles are called as the Grove sign. Bowing of the long bones can be seen. Pseudoarthrosis can be seen. Café au lait macules can be seen. How many café au lait macules is required for the diagnosis of neurofibromatosis? More than or equal to 6 café au lait macules are required for the diagnosis of neurofibromatosis. Somebody was asking the previous answer. The previous answer is atopic dermatitis. Atopic dermatitis. And what do you see in the eyes? Any findings in the eyes for neurofibromatosis? Anyone? Eye finding neurofibromatosis? Yeah, these are called as the leash nodules or the iris hamartomas. These are called as the iris hamartomas. So moving to the next one, buttonhole sign. Same disease, right? So what happens in neurofibroma? When you get these many neurofibroma, when you just try to press over these nodules, what happens? It goes inside like how you insert a button into a buttonhole. So this is called as the buttonhole sign. So where do you find it? But problem here, we cannot find the option of neurofibromatosis. So who can answer? Neurofibromatosis is also called as von Reckling-Hossen's disease, isn't it? So here the right answer is going to be von Reckling-Hossen's disease. We spoke something about DLE today. So about DLE, what we spoke was scarring alopecia. There is one sign that you can find in DLE, like the thick scaling that you have. If you just try to remove them, what is the name of the sign in DLE? Just remember this name. What is it? Carpet tack sign. Okay, carpet tack sign. Okay. Syphilis we also discussed. Now we did not talk much about tuberous sclerosis. Tell me what is a triad of tuberous sclerosis? It is by the name epiloia. Epiloia. So what is epi? Epi stands for epilepsy. LOI, low IQ. And what is A? A is not. So in syphilis, you get button sign. Okay, button sign, because the ulcer is very small, indurated ulcer. It's button sign. Buttonhole is seen in neurofibromatosis. Okay? Yeah, this one is not Ashleaf macule. Anyone who is saying Ashleaf macule, please correct yourself today, because this is angiofibroma of the face. Okay? Ashleaf macule is seen in tuberous sclerosis, but it is not a part of this triad, which is called as Vogt triad. So Vogt's triad of epiloia, which can be seen in tuberous sclerosis. Which can be seen in tuberous sclerosis. Next one, loagia, Ashleaf macule. Where is it seen? Direct question. It is seen in tuberous sclerosis. Now, what do you see in tuberous sclerosis, which can be seen over the nails, where there is a periungual fibroma? So there is an overgrowth just besides the lateral nail fold. It's called as a periungual fibroma. Can anybody name this one which can be seen in tuberous sclerosis? Very good, Abhishek. Anyone else? It's called as the, yeah, Kanksha. Tumor ka naam nahi yaad. What is it called? Keenan's tumor. Keenan's tumor. At least you remember that there is some tumor, right? Answer will be there in the options. Don't worry. Okay? So that is called Keenan's tumor. Shagreen patch can also be seen, Vivek. Very good. Next one. Flag sign in the hair. Zinc, vitamin C, xerophthalmia, protein energy malnutrition. Yeah. So this is seen in protein energy malnutrition. Where if the option was marasmus or kwashiorkor, what would be your answer? This is more common in kwashiorkor. It is more common in kwashiorkor. What do you call for zinc deficiency in a child? Zinc deficiency. Yeah, this is called as acrodermatitis enteropathica. It's called as acrodermatitis enteropathica. How will a patient of zinc deficiency present to you? They usually will present to you with DAD. What is D? Diarrhea. Very good. What is A? Yeah, A for not atopic dermatitis. A for alopecia. Alopecia. And what is the last D? Last D is dermatitis. Okay, peri-orificial dermatitis can be seen. That is how a patient can present to you with zinc deficiency. What do you call for vitamin C deficiency? Yeah, vitamin C deficiency is called as scurvy. And what is associated with xerophthalmia? Xerophthalmia is associated with which deficiency? This can be associated with vitamin A deficiency. Correct? So vitamin A deficiency is associated with xerophthalmia. Now all of you please note, for your exam, this is one of a very high yield topic where you usually get questions from this topic called nutritional deficiencies. Make sure you go back and spend some time because these are the places where you can guarantee score 2 or 3 marks for sure. Nutrition deficiency, be it categorized under whichever, biochemistry or PSM or dermatology, doesn't matter. But scoring on the day of the exam matters. Okay? So now next thing is going to be which nutritional deficiency is associated with the pruritic eczematous rash over the neck and the dorsum of the hand in a chronic alcoholic. Now remember, this is hinting towards a question or a topic which is always asked. So anyone who is answering B1, think twice. Around the neck. Okay, Cazel's necklace. Dorsum of the hand, gauntlet sign. This is gauntlet sign. And this is Cazel's necklace. What is the answer now? This is going to be vitamin B3 deficiency. Okay, that is niacin deficiency. So what happens here is, the moment you see alcoholic, you'll be running behind thiamine deficiency, vitamin B1, Wernicke-Korsakoff syndrome, all those things, right? So don't get confused. Whenever you get a photosensitive rash around the neck and a dorsum over the hands, gauntlet sign, Cazel's necklace, vitamin B3, niacin deficiency or niacin deficiency. Usually, what is the most predominant diet that the patient is on? The patient is usually going to be over, are they rice eaters, maize eaters, etc.? Yeah. So they are usually going to be maize eaters. They are going to be maize eaters. So here the diagnosis is going to be pellagra. Pellagra. So 100% the topic will be repeated. I don't know the question will be repeated or not. But remember 4 Ds of pellagra. What are the 4 Ds of pellagra? All of you in the chat box, please. 4 Ds, diarrhea, dermatitis, dementia, death. Okay, diarrhea, dermatitis, dementia, death. So please make sure you have a clear idea. Chronic alcoholics, please don't jump to vitamin B1. Read the question carefully. Think whether it is B1 or B3. Accordingly, answer. Okay? Next one. Patient presented with multiple painful blisters on erythematous base. So there is some vesicles, erythematous base, but it is along a dermatome. Along a dermatome, single side, or one side over the face, one side over the thorax, etc. What will be your answer? Yeah, so this one would be herpes zoster. What is herpes zoster also called as? It is also called as shingles. So in zoster, this is going to be the reactivation of which virus? Varicella virus. So what is the first infection with varicella virus called? First infection is always chickenpox. When there is a reactivation of the virus, then it is called as herpes zoster. What is the most common complaint because of which the patient comes to you? Is patient coming because of vesicles? No. The patient is coming because of a burning pain. So along with the burning pain, the patient is also having vesicles along dermatomal distribution. Along a dermatomal distribution. So tell me, what is the management also? Are you going to give or treat only the vesicles, or will you treat the burning pain as well? If yes, what is the treatment of the burning pain? What is the treatment of the burning pain? Starts with G, A, B, A. What is it? Gabapentin along with acyclovir. So gabapentin along with acyclovir has to be given, because what is the most common complication here? The most common complication associated with herpes zoster is post-herpetic neuralgia. So this burning pain, which is going to be present over this vesicular area, is going to persist for several months. That is why post-herpetic neuralgia is the most common complication, and we will have to treat it with gabapentin as well. Fine. Next one. A 3-month-old infant presented with a bright red mark as shown. Something that we have discussed. What is it? Capillary hemangioma, port wine, vascular malformation, nevus simplex. So this looks like a strawberry. So this is strawberry hemangioma. And as we discussed, it is not present in birth. It is not present in birth. And when will it appear? When does a capillary hemangioma appears? Yes, within the first few weeks of birth, isn't it? And what is another point for capillary hemangioma? By what age does the strawberry reach maximum size? Or maximum growth of this lesion happens till what age? Anyone? Up to 1 year of age. And then finally 90% regression by 9 years. And what is the name of the sign? Yes, the name of the sign is emptying sign can be seen. Emptying sign can be seen. So these are the important points regarding capillary hemangioma or strawberry hemangioma. So this is not present in birth. It appears within few weeks. It grows maximum up to 1 year, and then it starts regressing. 50% regression, 5 years. 70% regression, 7 years. 90% regression, 9 years. By 10 to 12 years, entire thing shall go away. Next one. Patient had a thorn prick while working in the garden. Now you have linear lesions spreading towards the shoulder. Already discussed, correct? Yeah, what is it? Yeah, this is called as sporotrichosis, which is also called as Rose Gardner's disease, Sporothrix schenki, and what was the star-shaped thing that you see in histopathology? Quick revision once again. Yeah, these are called as asteroid bodies. And remember, we already discussed about treatment. We treated with itraconazole for a period of at least 6 months. Okay, now let's see the next question. What could be the diagnosis for the image where exclamation mark is seen in trichoscopy? Yeah, most of you are getting it right. You say that this is going to be alopecia areata. Why do you say alopecia areata? Because even in syphilis, remember, even in syphilis, we can see something very similar. Multiple patchy alopecia. But in syphilis, we cannot see exclamation mark. Okay, remember, exclamation mark is seen in alopecia areata. So in alopecia areata, what are the important things that you will remember? In alopecia areata is a autoimmune disease. It's an autoimmune disease. Second one, this patchy alopecia can be seen. Patchy alopecia can be seen. The next one is that you can see exclamation mark sign. Sometimes a patient of alopecia areata will come to you with complaining of premature graying of the hair. But that is not actually premature graying of the hair. Can anybody give the name of that phenomenon? I think Pardeep has already answered. What is that name of the phenomenon? Yeah, Ashwin is also answering. This is called turning. Yeah, Mahesh, very good. Turning gray phenomenon. Turning gray phenomenon can also be seen. Now, in the same patient of alopecia areata, if you do a examination under the microscope, histopathological examination, you can see many lymphocytes coming together. There is a lymphocytic aggregation. And what is it compared to? Lymphocytic aggregation in histopathology. What is it compared to? Anyone? Exclamation was different. Exclamation was trichoscopy. Now this is histopathology. Histopathology is compared to, very good. So this is compared to a swarm of bees appearance. Swarm of bees appearance. Okay? And since it is an autoimmune disease, remember medicine, pediatrics, dermatology, anywhere, autoimmune diseases has to be treated with immunosuppressive agents, steroids, other immunosuppressive agents like azathioprine, cyclosporin, all can be used. But if I ask you what is the name of an injection which can be given intralesionally when it comes to alopecia areata, name of intralesional steroid in alopecia areata. Very good, Abhishek. This is called as triamcinolone. This is called as triamcinolone. Fine. Next one. Identify the image shown below. These are the kind of basics or the basic images that you can expect for your exam. They don't test you in very, very typical or rare disorders. What is this? Yeah, many of you are answering it as C, which is called as a carbuncle. Very correct. Now, what is carbuncle? Now, the difference between a follicular abscess, that is a furuncle, and a carbuncle is both are having pus beneath the skin. Now, this is an infection of a single hair follicle. And whereas carbuncle is going to be an infection of multiple hair follicles. So when you get a larger infection of the skin, sometimes you can expect an image behind the neck, because one of the most common site of a carbuncle, or anywhere in the body. So when you see these kind of multiple hair follicles that is getting infected, this is called as a carbuncle. In both the cases, what is the causative organism? The same causative organism. What is the causative? Causative is going to be Staphylococcus aureus. And whenever you find a pus beneath the skin, what is your treatment? Treatment, whenever there is a pus underneath the skin, the treatment should be the same. We have to remove the pus. Otherwise, it is going to be very painful to the patient. So remember, the treatment is going to be incision and drainage, and you can start on antibiotics. That is going to be the management of furuncle as well as a carbuncle. Clear? Yeah, I think that is it. That is the end of this discussion of dermatology. So I hope that, I think most of you are answering it in the TND. Most of you are able to give your answers correctly in the chat box. So please stay positive throughout the journey. Just few more days left. It is very, very important that not only to start better, to also to close it better, right? So stay positive. Don't bring down the confidence. Try not to get distracted during this last phase. Just try practicing more MCQs. Okay, try to work on your mistakes. And I'm sure that all of you will be able to cross the 150 mark this time. Okay, all prayers for you. If there is anything additional that I should address during this session, happy to answer. Okay. So I'll be sending you this annotated PDF right away, and just go through all these things. And please make sure before you go for your exams, regarding dermatology, one thing is very clear. 5 questions from general dermatology can be expected. But if you try to club whatever you have learned in dermatology, you can get more questions in association with microbiology, pharmacology, etc. Okay. And also you can correlate it with biochemistry and all when it comes to nutritional deficiencies. Okay. So please make sure you go back and learn and revise something about psoriasis, sexually transmitted infections. Okay. Vitiligo. All these are very short topics like vitiligo, nutritional deficiencies, etc. So all these things very, very, very important. So when you learn psoriasis, please try to compare psoriasis with lichen planus, because these are the two areas that is always asked. And then along in the vesiculobullous diseases, at least, even though it is a big chapter, at least quickly go through pemphigus group of diseases and bullous pemphigoid also, and bullous pemphigoid also, because for the infections part, for the skin malignancies and all, when you go for your exams, when you see the image, whether you have prepared or not, I'm sure that the probability of getting those correct is more. But these are the topics which you will have to go through once, and then just do this quick revision and then go for your exams. Okay? Please practice MCQs. Practicing MCQ is the key. Fine. If there is anything, always feel free to reach out to me. Difference between papulopustular rosacea. See, SLE, malar rash, they will mention all the time in the MCQ, butterfly rash. In papulopustular rosacea, right? Red face, there will be some acne kind of lesions over the face. And the question will tell you flushing, worsening on alcohol, worsening on spicy food, etc. Okay, Ashwin? So I hope that is it. Okay, thank you. All the best. Rock the exam and come back in flying colors. Fine. Thank you. Thank you, Pardeep. Thank you all.